You are all welcome, but let me give that opportunity to the person who was given the responsibility to do that. So without any waste of time, let me just make a few announcements before we start. The Wi-Fi is there on that, and I think the password, you use the Safari. If you look at the Wi-Fi, the Safari, and the password is Safari 123, starting with the S in caps. So the bathrooms are on my right. Then we will have tea. I think you have already have tea. I don't need to indicate where we will have your tea. May we please switch off our laptops and cell phones because we will be needing your full attention. The plenary sessions will be held in this room, and we have breakaway rooms. There are 2 rooms you'll see in the program where you'll need to go for session 1A and 1B and 1C. So 1A will be in this room, 1B will be in the chapel, which is the room next door, and then the other room that will be used is called Marilyn, which is next to the restaurant. So the judging panel, please be available, and you'll get the judging material from the organizers. Then we'll be very strict with time. If you are given 10 minutes, please take 10 minutes or take the allocated time. And then remember, the conference is CPD accredited, so there will be forms to fill at the registration point. So without any waste of time, let me call the DVC Teaching and Learning Prof. Madadze, who will give us the opening remarks. Over to you, Prof. Can we have a round of applause?
Program Director, Mr. Choma, don't be surprised that I'm delaying a bit. I was struggling when I looked at the stage, whether I should accent the stage using the left side or the right side. And because the podium is in the middle. So where should I go? Should I go left? Should I go right? And ultimately I said, well, it doesn't matter. What matters is what one is going to say, which also affects you. That what is going to matter is what you are going to present to us. Mr. Choma, the Vice Chancellor in absentia, is because we also have another workshop close by in this same venue. Professor Mutiba, the DVC for Research, Innovation and Partnerships, was supposed to be here now, but we felt we cannot all be absent from where we are. Let one of us be here for a short while, which then means if I were to leave midway, don't take umbrage, is because your university has grown a lot. Like this week, I think we had more than 5 functions at a go, which means you are part and parcel of a lively, functional institution. The Executive Dean of the Faculty of Health Sciences, Prof. Bupape, Directors of School, Professor Baloy and Professor Sitole, the organizing committee as a whole, under the stewardship of Professor Goon, the research professor. I can see we also have heads of departments. We also have professors among ourselves. We also have guest speakers, even if some of them may not be currently here. But I did note from the program that Dr. Mokari is one of the guest presenters, Professor Litsika from UNISA, as well as Professor Baker from Sifako Mahato University. And of course, we have academics and support staff who are helping us to coordinate activities during this important conference. And of course, presenters of papers, and more importantly, to us as an institution, the students who are also going to present. Ladies and gentlemen, I would say all protocol observed. I'm not excluding our ICT, marketing, and communication colleagues who are making sure that we are like flighting online or virtually. Good morning. I thought health professionals are so good in greeting. Good morning. Thanks very much. On behalf of the Vice Chancellor, Professor Mokhalong, it is indeed a great pleasure and privilege for me to be present at this year's August conference of the Faculty of Health Sciences. Therefore, I would like to take this opportunity on behalf of the Vice Chancellor to welcome you all to the 2025 Health Sciences Research Day Conference. And of course, under the capable leadership of Professor Bupape and a capable organizing team, as I said, led by Professor Goon. A special word of welcome is extended to all our guest presenters. I've already mentioned them. Colleagues, to all of you, we look forward to listening to your presentations. And of course, organizing a conference from its conceptualization to actual presentations is no mean achievement, or is no mean feat. As an outsider, sometimes you might take it for granted that it is so easy to arrange or to organize a conference. It's not easy in the sense that you have to contact various stakeholders, our support staff, our academics, and you also have to look at our calendar. Some of the students I know are busy with their practicals, so we have to ensure that our students, even if they are going to be presenting today, they must also not lag behind in terms of meeting their notional hours when it comes to clinical training. So it's a big job. And for the faculty to have such a conference commencing on time, I think it deserves a big round of applause. Can we give yourself a big round of applause? Colleagues, it is highly encouraging that when one looks at the presentations, they are so relevant, they are so apt, they are so up to date in the sense that the conference is going to deal with various issues pertaining to health. Of course, you have a major theme like health coverage or national health coverage, who should receive treatment, who should not receive treatment. I think it's a moral dilemma that you as professionals in your careers are going to have. If there is only one medicine or medication for one person or for one patient, between a person like myself who's old and somebody who's 5 years old, and there is only one medication, who are you going to choose between myself and that 5-year-old young girl? You may not answer me now, but this is something that we have to ponder. That what do we do in such an instance? Are we going to play God now and say, well, this one is more important than that other one? These are some of the issues that I see you are going to be dealing with in your presentations. So a conference of this nature is indeed very, very important. It is also heartening to note that some of the presenters are students. We can not be more proud, really, to have students presenting. I don't want to embarrass you, but take it in a good way or in a good spirit. Can all the students raise their hands? Don't be ashamed. I'm also a student. Thanks very much. Thanks very much. I see most of the presenters are students. As an institution, we would like to congratulate you on being so brave, in the sense that presenting a paper is not as simple as it looks. Even the seasoned scholars still find it tough to present a paper. I trust in your case you have had very good mentoring, very good guidance from your supervisors. I think your papers have like a problem statement. You have research methodologies. Who is going to use quantitative methodology as an example? Don't raise your hand now, but I'm just asking this as a rhetorical question. Who's going to use a qualitative research methodology? And in your field, I've gone through some of your presentations and even some of your studies. You often go for the mixed method research methodology, which means you are very important people, because if you can tackle this one, mixed method, in other words, you are combining quantitative and qualitative at a go, and then you come and present your analysis or your data, and you come up with findings and recommendations, then it means you are quality students. You are quality scholars. And this is going to stand you in good stead wherever you go in the world. That indeed, if you were to get a qualification from us here, we hardly have any doubt that you are fit as a health professional to practice anywhere in the country, anywhere in the world. I was so envious of somebody when we interacted with him, I think 2 years or so ago. He came to us and said, "Hey, Prof, I'm leaving." Then I said, "Where are you going?" He said, "Canada." Then I said, "How?" does Canada recognize our qualifications? He said, yes, Canada does. I'm just using that as an example to show you that the qualifications that you are going to gain through presenting papers of this nature are not to be underrated. You are indeed quality students. And of course, our gratitude goes to all the supervisors. I'm also a supervisor part-time, and we know it's not an easy thing to be a supervisor because a student will submit his or her proposal by today, and by tomorrow he or she will be demanding feedback. But our supervisors, I know, are committed, and they guide our students very well. And for that, we cannot thank you enough. Now, to our students, lastly, if you are going to present for the first time, take it from some of us, there's nothing to fear. There's nothing to be afraid of. You come here, you tell yourself that you are the best candidate who has ever presented a paper of this nature, because your paper is unique. No one has done that paper in the past or even in the present epoch. You are the only one. So you are the expert. Feel confident. Don't be afraid that so-and-so is going to pose a difficult question. Even if they pose a difficult question, you answer them confidently and say, that is a very good question, sir. I'm still going to read more literature on it. And then you are covered. Ladies and gentlemen, I'm not here to proffer or to present or to give a speech really, but on behalf of the Vice Chancellor, we are highly proud of you, all of you, students, academics, support staff, wherever we go. I was whispering in the ear of the executive dean there, and I said, hey, I'm so envious of you. I wish I were in your shoes, where I will be part and parcel of this important cohort of professionals in the country. With these few words, ladies and gentlemen, feel at home, do the best that you can, and some of us are not going to be here, as we said, but we'll be also watching you virtually. And we can only wish you success and all the best. If there are going to be awards, which I think are going to be there maybe, if you don't receive an award, don't be worried. By presenting, you have already received an award. Ladies and gentlemen, thank you very much, and we wish you all the best.
Thank you, Prof. Madaze, for the wonderful welcome. I could see in the faces that the colleagues are welcomed. We will be moving into the next part of the, let me just put this here, part of our program, which is a speech by our guest speaker. The guest speaker is Dr. H. Mukari, and he will be giving a topic titled Advancing Universal Health Coverage and Promoting the Well-Being of All Individuals. Dr. Mukari is a qualified dental therapist, a medical doctor by profession with MBCHB from the then Medunsa, now Sefako Makhatu, University of Health Sciences, where he qualified the MBCHB in 2001, and he has a very extensive experience in clinical medicine, management of both public and private sections. His passion on health policy made him to register for the postgraduate diploma in health economics with the University of Cape Town, where he graduated in 2024. Dr. Mukhari is currently serving his second term as a council member of the Council of Medical Schemes, where he is the deputy chairperson of the council and a member of the executive committee. He is a community health activist with special passion and commitment to advocacy in the implementation of national health insurance. He is a member of the National Executive Committee Progressive Professional Forum, where he is the national convener for NHI. He is currently working as policy consultant on health economics and medical advisory. May we all welcome Dr. Mukhari.
Colleagues, good morning to everyone. As introduced by the program director, Dr. Onas Mukhari, but I would like just to acknowledge some of the some of the leadership of the University of Limpopo that may be here and may not be here. The Vice Chancellor of the University, Professor Mahlum Holong, the Deputy Vice Chancellor, Teaching and Learning, Professor Richard Madache, Acting Deputy Vice Chancellor, Research, Information and Partnerships, Professor Tia Mutiva, Acting Executive Dean, Faculty Health Sciences, Professor M.A. Bupape, Executive Dean, Professor Humanities, Professor R.S. Mahutu, Acting Executive Dean, Faculty of Science and Agriculture, Professor Lislane Mampuru, University Registrar, Professor J.K. Masha, Director of School of Healthcare Sciences, Professor H.S. Zitole, Director of School of Medicine, Professor S. Baloi, other directors of various schools and units that are here, Director of Research and Administration, Dr. T.E. Mabila, all HODs that are present here, Research Day Conference Organizing Committee members, and we appreciate that you have invited us to be a keynote address and to share information on universal health coverage. Postgraduate, undergraduate students that are here, ladies and gentlemen, all protocol observed. Colleagues, when I was invited to come and give a keynote address, my dilemma was, is that an address? Is that a presentation? But when I look at the topic of universal advance towards universal health coverage and promoting the well-being of all individuals, I said, irrespective of whether it's a keynote address or a presentation, what is important in this topic, it's information. And for the fact that we are presenting to you as researchers, as academics, and we think that the information that we are going to share with you, whether as an address or whether as a presentation, it is of relevance. We have shared this keynote address in the interest of time, whereby we may not be able to finish the presentation within the allocated time, but we will try our best to do that within the allocated time. An interesting topic and very relevant topic indeed, advancing universal health coverage and promoting the well-being of all individuals. The two parts of this theme actually talks to each other, because you need to promote well-being of all individuals in order to advance the universal health coverage. You need to promote the well-being of all individuals in order to advance the universal coverage. The big question, which is what we'll try to share with you here, is the how part of it. How do we promote the well-being of all individuals and advance, in order to advance universal health coverage in the country? That is the big question. The theme talks to each other. The how part of it is what we are going to present this morning. But the how part of it, ladies and gentlemen, colleagues, needs a mindset change. We cannot understand the how part of it based on the current mindset of the current healthcare system. Because universal health coverage, it's a paradigm shift. It's a complete shift from the kind of health system that we have in the country. So we have to have that mindset change in order to understand it, especially you as academics and researchers. If you have to make that research but based on the current, you'll get it wrong completely. Because when you use the mindset of the current system, the universal health coverage is impossible to achieve. But when you change a mindset and understand how it can be achieved through the type of national health financing system, then it will be easy for you to understand how it will be achieved. So that is the information that we will try our best to share with you today. This theme is not merely an academic exercise. It's a call to action, a moral imperative that speaks to the very heart of our nation promise of a right to quality health care to our people. This is enshrined in our Constitution in Section 27, subsection 1, which states that everyone has a right to have access to health care services, including reproductive health care. And Section 27, subsection 2, which further oblige the state to take reasonable legislative and agile measures within its available resources to achieve the progressive realization of the right of access to quality health care services for all. So universal health coverage, it's a constitutional mandate of our country. Before we can embark on this journey towards universal health coverage, it is important to reflect on the historical part of the healthcare system in South Africa, the systemic and structural challenges and the deep injustices and inequalities that continue to shape our health system. For decades under apartheid, quality healthcare access in South Africa was based on race. The advent of democracy in 1994 was a watershed moment that began to dismantle the legacy of apartheid and all race-based policies. However, under the democratically elected government, a new form of discrimination in access to healthcare has emerged, whereby discrimination to quality healthcare is based on affordability and not on health needs. Those with financial means could access quality healthcare in the private sector, while the majority, particularly the poor, the working class, and the unemployed, remained dependent on an underfunded and overstretched public healthcare system. This divide is starkly reflected in the resource allocations in the private sector as compared to the public sector. The country is currently spending 8.5% of its gross domestic product on healthcare. 8.5% of the current country's GDP is spent on healthcare. More than half of it, which is 4.5%, is spent on private healthcare, which only services 16% of the population. The other 4.3% is spent on public health care, which services 84% of the population. This is the current state of our healthcare in the country. Between the private, which is well funded through what is spent from the GDP, and the public sector, which is poorly funded. But ladies and gentlemen, those that are opposed to the universal health coverage says that this GDP spend of 8.5% is private money. They justify it that the fact that the private sector is being allocated more than half of the GDP to cater for 16% of the population. They say that it is private money. However, it is important, colleagues, to know that everyone contributes towards the GDP. The rich, the poor, contributes towards the GDP through household spending on goods and services and other economic activities. Everyone in the country, the GDP is the wealth of the country. Everyone, rich and poor, contributes towards the GDP of the country. But yet, more than half is allocated to only 16% of the population. This is the challenge that we are grappling with at the moment. And the achievement of the universal health coverage seeks to correct it. The question is, how is it corrected? This type of statistics are an anomaly which is not sustainable for a country and demonstrate the deep structural and systemic inequalities in access to quality healthcare for all. These challenges are the very injustices that the National Health Insurance seeks to correct by achieving the universal health coverage for all. The National Health Insurance is an equalizer which will ensure a healthcare system that is fair, equal, with equal access for equal needs for all its citizens. Initially, I said the topic is advancing universal health coverage and promoting well-being of all individuals. And I said, but how do we promote the well-being of all individuals in order to achieve universal health coverage? And in the South African context, that intervention of the how part is the National Health Insurance. The NHI is not an event. It is a process and a journey that will be implemented in phases towards achieving universal health coverage for all. It is the strategic mechanism to dismantle the financial and structural barriers that sustain the current status quo. The signing of the NHI Act into law marked a significant milestone in the country health policies towards achieving universal health coverage. And we can report that a lot of progress has been made in this regard amid the legal challenges by those opposed to NHI. One of the most important progress that has been made is that the Minister of Health, Dr. Aaron Motsoaledi, has already published government regulations for public comments. That was published in March, and the public was given until June to comment. Upon the gazetting of the governance regulations by Parliament, the National Health Insurance Fund will be established, and the board to oversee the implementation of the NHI will be appointed. The first step has been taken post-signing of the Act, which is the governance regulations. I am hopeful that before the end of the year, the fund will be established after it has been gazetted in Parliament, and a board will be appointed. Then that will be the beginning of the implementation of national health insurance in order to achieve what we seek to achieve, which is the universal health coverage. But how will the implementation of the health insurance advance the country towards universal health coverage? How? At its core, the universal health coverage means that all people must have access to quality health services they need when and where they need them without financial hardships. This guarantees financial risk protection so that no individual or household is driven into poverty or financial burden due to a healthcare need caused by an unaffordable healthcare service. Allow me, ladies and gentlemen, to present to you as to how will the NHI advance universal health coverage. The National Health Insurance is a financing system that will ensure that every South African is able to access quality health care without suffering any health risk. And national health insurance is not just a South African phenomenon. It's important to note that many governments across the world are actually moving towards the universal health coverage. And the universal health coverage, it's a resolution of the United Nations Sustainable Development Goals. Goal number 3, which talk about health and wellness. So when we speak the national health insurance, it's just a South African means of a national health financing system in order to advance towards the universal health coverage. So the national health insurance is an enabler of the universal health coverage. National health insurance is an enabler in terms of the health financing system. But it's also important to understand how will the NHI differ from the current healthcare system. We have already presented that the current healthcare financing system is based on affordability. User fees are charged at public hospitals, out-of-pocket payments for health services, co-payments with medical aids, and voluntary health insurance with medical schemes. The national health insurance, the national health financing system is not based on affordability. That is the key difference. But it will be predominantly funded through a general revenue allocations from the National Treasury, which will be supplemented by the involuntary mandatory prepayment system in the form of payroll tax payable by employers and employees. All what we are saying here is you have to understand the difference between these two systems. The current system, you get quality health care based on what you afford or not. But with national health insurance, affordability doesn't come into play. There will be allocation by National Treasury, which currently is, when it's allocated, it goes to all different provinces, it will be put into a single fund. As it becomes, many people are covered, and then there will be mandatory contribution to supplement what Treasury will allocate for national health insurance. But as we said earlier, we need key mindset and behavioral changes to understand the NHI system And key amongst them is that the current two-tier system is hospice-centric. It's important that we understand that in order to understand how NHI can achieve universal health coverage. The current healthcare system focuses primarily on sick people when they already have symptoms and complications, while NHI will focus on health and wellness of the population before people get sick. This speaks to the second part of our theme, promoting the well-being of all individuals. NHI will focus on health and wellness of the population before they get sick. The population will be screened and tested for diseases at their households, at their schools, at churches, at workplaces, at community centers, and so on. This will result in fewer people who will become sick and requires hospitalization. Currently, the autism have symptoms, but the NHI information would have happened long before this focus on prevention, focus on health promotion, education, rehabilitation, palliative care. So let's go to hospital and be brave for it. Of ensuring that people don't get sick. Healthcare providers at that level, nurses, dentists, general practitioners, optometrists, they will be paid in advance. So the mindset change must change from the fact that we are used to, but government won't, this NHI won't pay us on time. And but how much is the mindset because but we in advance as per habit. For the population. So it's important that we understand the context. Secondly is the hospitals. Also the hospitals. They'll be through a model that is called dual budgets. Hospitals will also be in advance to take care of the people that will have been referred to the hospital. Then you get another layer of specialists. Also, specialists will be paid based on a payment method called diagnostic related group. They will be paid based on the diagnosis. At the primary healthcare level is capitation. The service providers will be paid in advance to ensure that people don't get sick. When they refer a patient to the hospital will have been paid by NHI already through the Global Fund. When the practitioner refers to a specialist will be paid based on the diagnosis, but the specialist will be paid after they have offered the service. All these service provider payment methods, ladies and gentlemen, are used globally. Every country that is implementing universal health coverage or moving towards are using these methods, either alone or in combination of the methods, payment methods that have already presented. It is also important to know that the NHI fund will not purchase benefits that the country cannot afford. The fund will only purchase benefits in phases on behalf of the population in accordance with the available resources and within its allocated budgets. Therefore, the issue of whether the country can afford NHI or not does not arise. Based on the available resources, then the NHI fund, the board, will decide, based on the resources that we have, which services can be covered or which benefits can be given to the population based on how much resources we have. So it will be based on the available. Hence, it will be implemented in phases. The fact that it's implemented in phases is because it's dependent upon the available resources. The role of private healthcare providers will continue under NHI, and the new NHI fund will purchase and pay their services on behalf of the population. Private healthcare providers will continue to render their services in both public and private sectors. The difference is they will now be paid by the National Health Insurance Fund, not medical schemes and not out-of-the-pocket payments for the services that has been identified as benefits to the population. It is important to note that the access to healthcare will be free at the point of care, which is the primary healthcare. All South Africans, permanent and legal residents in South Africa, will be covered by NHI. And undocumented illegal foreigners will not be covered under the NHI, except in emergencies or notifiable diseases to prevent risk of disease transmission. All users will be required to register at the nearest accredited primary healthcare facility or service provider of their choice through a biometric system and by providing proof of identity and proof of residence. This is in itself will be a solution to the current challenges of overstretching the public healthcare facilities by those that are undocumented in the country. So to have access, you'll have to be registered through a biometric system. Users, which is the population, will be required to get healthcare services where they are registered. You choose where to register, and when you are sick, you'll have to go and consult at a doctor or service provider where you are registered. However, the NHI Act makes a provision for special portal for access to service if you happen to be in another province in the country. Of importance is that users will have to comply with NHI referral pathways. In this case, you consult the doctor where you are registered, who will then refer you to a hospital if it's necessary, or refer you to a specialist. Users will have to comply with these referral pathways in order for their services to be covered under national health insurance. All those covered by NHI will be entitled to the same health benefits delivered in a fair and equitable manner, irrespective of their economic status and standing in the community. Many of you sitting here this morning might be worried about the quality of care under NHI, especially in the public health facilities. Ladies and gentlemen, the issue of quality health care is well covered in the Act. But of importance is that service providers, whether it's private or public, they'll have to conform or comply with minimum standards in order to be accredited by National Health Insurance Fund. Therefore, it is not every hospital or every clinic or every practitioner who will offer services to NHI fund, because NHI fund primarily focus on quality of care. That facility has to be accredited. Government is already rolling out the quality improvement plan in clinics and hospitals. But the Act has also made a provision for an Office of Health Standard Compliance, which inspect and certify facilities and private healthcare providers first before they can be accredited. The standards will be the same. The type of standard that you get in Netcare must be the same of standard that you get at Mangwe or any other hospital. The hospital's service providers for NHI, the standards will be the same, and the conditions of accreditations are the same. So the issue of quality, care, infrastructure, and so on doesn't arise, because facilities that don't comply will not be service providers, will not be accredited for national health insurance. Colleagues, ladies and gentlemen, many of you attending this conference are covered by medical aid schemes. And you might be worried as to what role will medical scheme play under NHI. Furthermore, you might also be worried about whether you are expected to continue paying premiums or not. Allow me to clarify, ladies and gentlemen. The role of medical schemes under the National Health Insurance is covered clearly in Section 33 of the Act. Medical schemes will still exist under NHI. However, once NHI has been fully implemented as determined by the minister, medical schemes may only offer complementary cover for health benefits that are not covered by the NHI fund. If the NHI fund covers consultation with general practitioners, dentists, pharmacists, optometrists, and so on, and covers admission to the hospital, and covers referral to the specialist, it means that medical aid schemes cannot cover those services. We had said it will be implemented in phases. So as more benefits are covered, medical aid scheme cannot cover those same services. So with time, you can see that the role of medical aid will slowly diminish. Whether members must continue will be up to members themselves. Here it is, you have got the NHI card, which gives you access to your own doctor, specialist as referred, or hospital as referred. Then it's up to you whether you still want to be part of medical aid or not. But medical aid scheme cannot cover those services that are covered by NHI. This is the key principle of NHI in order to ensure universal health coverage. Ladies and gentlemen, we are gathered here as academics and professionals. We are aware that some of our colleagues who are healthcare professionals are unemployed and are sitting at home. There are also others completing their community service but facing an uncertain future regarding their employment. This is a very unfortunate situation because there is a significant shortage of healthcare workers across all provinces. And yet, healthcare workers remain unemployed. We hope and believe that government will urgently provide a solution to this baffling conundrum and paradox. At the same time, we must recognize the opportunities that NHI will bring in terms of employment of healthcare professionals. At the primary healthcare level, doctors, other allied professionals, nurses, community healthcare outreach workers, health promoters, health educators, integrated health services providers, home-based care workers, cooperatives. at the primary healthcare level, there will be many employment opportunities and many business opportunities. More jobs will be created under the redesigning of the primary healthcare. At the hospital level, doctors and other allied healthcare professionals can be employed at both private and public sector hospitals. Another mindset change, colleagues. Currently, doctors and other healthcare professionals are only employed at public hospitals. The regulations of the HPCSA does not allow doctors and healthcare professionals. You'll never have heard of a doctor saying, I'm working at. They offer service there, but they're not working, they're not employed. So NHI, as we had said, will accredit it. There won't be a difference between a Netcare and Makweng Hospital. Both of them will be healthcare service providers, and both of them will be required to employ doctors. Based on the number of beds, the regulation, the requirement will be, for this number of beds, you need to have 20 medical doctors, 10 dentists, 5 optometrists, and so on. So that is a new opportunity which will absorb all the unemployed doctors. The issue of unemployment of doctors won't arise. As a matter of fact, we'll have a shortage because opportunities are in the public sector and the private sector, and the conditions will be the same because the payer is one, which is the National Health Insurance Fund. So whether I work in Mankweng or I work in NK, the conditions of employment will be the same, 100%. That regulation that prohibited doctors or healthcare professionals to be employed in the private sector has been amended on the 25th of February 2025. Now, doctors, healthcare professionals are allowed to be employed at the private sector for the purpose of NHI. It has been amended. As soon as NHI board and the NH fund is established, that will kick in. There won't be any difference. So the issue of unemployment will be cushioned against because there will be more opportunities. Internship, public. So the issue of employment of professionals with increased resources. We have the vision, the strategy, and most importantly, the intellectual property in this very room to make it happen. And let us be fortified by the decisive clarity of our current Minister of Health, Dr. Aaron Motsoaledi, who reminded us during the State of the Nation address debate that nations do not embark on this path from a position of excess wealth, but from a position of necessity. All that is the world who have implemented universal. This will not cause the rich. No, the opposite is true. They all started their universal because of this purge by means of a crisis.
Dr. I. Rukashi, Dr. M.G. Tau, Dr. I. Rukashi, Dr. M.G. Tau, Mr. Maringa, Professor T.S. Neti Papami. Maringa, Professor T.S. Neti Papami. May you please see Prof. Ematebula. See Prof. Ematebula. Okay. The other announcement is that remember we are going to the break rooms. As indicated in the program, A1 will be this room. And the 1A is this room, 2A indicated as the presenter might not be available. So make the chairperson aware that who will be presenting, and also make sure that he's aware that, or he or she's aware that you are available. Thank you, colleagues.
Now it's 10:30. So we are 15 minutes behind, which means we'll have to run. All right. May I get to know which session is this? Is this session 1A or session 1B or session 1C? 1A. Great. Thank you very much. We're going to hear presentations in the theme for maternal, newborn, and childhood. Okay. So that person was not lost. So at least I'm familiar to that. Our first presenter will be Sibula. Sorry, not Sibula, but Malope P, who did a study on lived experiences of mother regarding care of preterm babies in the Capricorn District province of South Africa. You are only given 15 minutes, not more than that. Actual fact, they are very lenient. If you go to the international conference, it's 8 minutes, 2 minutes for questions. So practice that one. It's Malope here. Welcome, please. Thank you. Huh? Is it not right? Oh, okay. Enjoy. So you must give us 5 minutes so that we can ask you questions. Questions are not aimed at bringing you down, but to beef up your project for international presentation.
Good morning. As they've said, my name is Pito Malope, and I'll be presenting a study on lived experiences of mothers regarding care of preterm babies in Capricorn District, Limpopo Province, South Africa. Preterm birth is a global burden wherein we have over 13 million of babies born prematurely in a year. And South Africa is one of the top 5 countries in Africa with the highest rate of preterm birth, at 84,000 babies born prematurely in a year. Despite all these high prevalences, we still have a huge gap in literature regarding the lived experiences of mothers caring for their preterm babies in Limpopo Province. The objectives of the study is to explore and describe the lived experiences of mothers on the preterm babies admitted in Neonatal unit in Capricorn District, Limpopo Province, South Africa. And the research question that guided the study throughout is, what are the experiences of mothers caring for their preterm babies in neonatal units in Capricorn District, Limpopo Province, South Africa? This is a phenomenological research wherein phenomenological research design was used in the study to delve into describing the lived experiences of mothers caring for their preterm babies. The study population was all mothers of preterm babies admitted in neonatal unit and pediatric ward. In-depth one-on-one interviews were conducted with the mothers, allowing for a rich qualitative exploration of their experiences caring for their preterm babies. A descriptive coding was used to analyze the data. On analyzing the data, 4 themes emerged. The first theme is anxiety experience, where mothers feared to carry out their maternal roles, where one of their mothers indicated that birthing her baby was difficult because her baby was small. So she was scared to hold the baby, thinking that she might end up breaking her baby's neck. And the second theme that emerged is traumatic experience, wherein mothers experience shock and anger and also emotional trauma. One of the mothers also indicated that when she arrived in the neonatal ward and they showed her baby for the first time, she was shocked because her baby was small. So all she could do was to cry at that moment. And the third theme that emerged was loss of hope, wherein mothers feared that their babies might not survive. And one of the mothers indicated that when she saw her baby small, she thought to herself, is her baby going to survive? And during that time, she had a lot of things going in her mind. She even lost hope. And the last theme that emerged was hospitalization experience, wherein mothers had to adhere to the hospital routine and also the long-term hospital stay. One of the mothers expressed that they have to wake up in the middle of the night to go and feed their babies. So she was forced to do that because all she wanted was to see her baby being discharged in the hospital. Behind every small preterm baby, there is a mother experiencing, carrying a huge load of fear, hope, and resilience. So supporting her emotional and psychosocial well-being is as critical as caring for the baby's well-being. So these are the recommendations that we have in exploring other mothers' experience in other healthcare facilities. And the other recommendation is to bring awareness to lived maternal experiences in neonatal care settings, where mothers who have experience in caring for their preterm babies, they can share their experience with other mothers. And also support the design of targeted interventions for maternal and neonatal care, wherein we do not focus only on the neonatal care and also the maternal care, wherein we can have peer support groups for the mothers and counseling, and also enhance and also enhancing policies. And also enhancing policies and promote family-centered care, wherein, because mothers express that they get tired and they have to care for their neonate throughout the day and throughout the night, family-centered care gives chance to family members to also assist the mother in caring for the neonate. So this way, the mother can have an opportunity to rest. In conclusion, the findings of this study reveal that there are challenges mothers experience when taking care of their premature babies in hospital. Therefore, addressing these challenges requires tailored psychosocial support, peer support program, enhancing family-centered practices, and a system improvement in neonatal unit environment to better support mothers and improve neonatal outcomes. With that said, I would like to acknowledge the mothers who participated in the study, and also the Department of Health for allowing us to conduct the study in their healthcare facilities, and also the supervisors for their support and guidance. Thank you.
Okay, what a good study. Can we get some few questions? I think we still have 3 minutes for you. Dr. Mashaba. Do you have a Robbie mark here? You can shout. While they're waiting for the mic, I just have only 2 questions. What was the age group of these mothers, and what was the common cause of the preterm? That's it.
Morning and well done on a well done study.
Thank you.
I would just like to know if you explored the economic effects of caring for a preterm, like how many mothers were breadwinners and how many of them lost their jobs because they now had to be in hospital for a few weeks or months. Did you explore that part?
Okay. Thank you for the question. That is a very good question. We did not go into exploring that, but it's an eye-opening, and thank you for that. So we will explore into it further to see how caring for your baby in a hospital affects you economically. Thank you. And on the age group and the causes of preterm birth, is it? Okay, so the study focus was on their experiences on caring for their preterm babies in hospital. So the causes of their preterm babies was not given attention into details. The attention was only focused on their experiences while they are caring for their preterm babies. Thank you.
So the age group?
Oh, yes. And the age group, it was all the mothers of preterm babies, caring for their preterm babies. So there was no strict age group. It was all the mothers.
Yeah, but when you analyze, was it the young ones or the elderly ones who were the most predominant? If you have looked into that, the age group were the dominating these preterm mothers.
The dominating age group, would say it was around 25 to 35.
Okay. Right. Thank you very much. A research which does not initiate questions is not a research. So that research has initiated a number of them. And one of it is a follow-up research on the impact, the financial impact burden. That's a very good study. If you have that, then you can even publish it even in some financial high-impact journals. All right. Then you will need to go back and reanalyze the causes or the underlying of this preterm and the age group, because probably the ones who were most scared might have been the young ones. And therefore tells you there's a problem with contraceptives and all this. Thank you.
Thank you.
Wonderful. Right. We move on to the next presenter, Rapolo M. I am just remembering Rapolo because he was my general in the army, who is going to present about patterns and outcomes of pediatric solid tumors, a surgical review from Limpopo's Pediatric Surgery Unit. And this presentation should feature on the 29th. Prof, this presentation should feature on the 29th of September during the National Cancer Research Initiative. Welcome, sir. Enjoy.
Thank you.
You also have 15 minutes.
Okay. Okay, morning, ladies and gentlemen. So as they had outlined, my presentation today will be as follows. So I'm going to start with the background. The Pediatric Surgery Department in Mankweng is the only such service in the province. So it is established to address the growing demand of the specialized surgical care in the province. It is operating within a limited resources and understaffing. So this study that we did, it just aims to review the pattern spectrum surgical management
and early outcomes of our solid tumors that we've seen in our province, Limpopo. Introduction. The pediatric solid tumors represent a formidable challenge in the realm of pediatric oncology, imposing significant burdens on the affected individuals, families, health and healthcare system worldwide. These tumors are just characterized by uncontrolled proliferation of abnormal cells in various organs or tissues. It encompasses various malignancies with distinct clinical presentation, treatment modalities, and outcomes. And our aim when doing this study is just to review the burden of solid pediatric tumors in this province, characterized by the demographics of pediatric solid tumors, including gender disparities and regional variances. We investigate the spectrum, the surgical management, and the early outcomes of solid tumors operated in this unit. Our study was just a retrospective observational study of a period of 12 months. So our population, we focused on the patient of the age from 0 to 14 years. Our inclusion criteria was all pediatric patients with solid tumors that we operated. So there was no concern because this was a retrospective study. Our data collection, we used the files of the patients, pediatric oncology database, pediatric surgery database, and the theater database. So all the data was put all together. So we collected the data that we collected to demographics. We went surgical intervention and post-operative outcomes. So this is just a presentation of our data. We had a total of 24 patients that we've seen in over 12 months. 13 of them was females and 10 of them was males, which is 56% to 43%. So our results, the most common, our results was the most common district that the most common patient, the most common district that we see. We have the patients that are coming from Vembe mainly, and also Capricorn. These are the major contributors to that have presented with the tumors. So our tumor types that we see mainly in Limpopo, the most common ones, with 56.6%, it's the nephroblastoma. And we followed by the germ cell, which is about 13%. And the others that as outlined here. So there are only three, we had only, out of all the tumors that we've seen, we only had three, and the most common with metastasis, the most common metastasis was to the lungs. Out of all that, we had, this is just a discussion where we had 24 patients over a period of 12 months as compared to other units. In South Africa, we looked at the unit Chris Hani Baragwanath Academic Hospital, which has done a study about for 10 years, which sees about 387, which is approximately 38 cases in a year. And we looked into Africa. They have about they've done a study of 181 cases in 5 years, which is approximately 36 cases in 1 year. So in India, we had about 93 cases, which is about, in 7.5 years, which is approximately 12 cases, and Bangladesh. So this, as compared to other countries, we can see that we are also on the same page with other countries as a unit, as a newly established unit. Then when we look into the histological types, so we have the most common in Limpopo that we see is the nephroblastoma and the germ cell tumor. And then when we look in other hospitals in the province, we have about nephroblastoma, rhabdomyosarcoma. And Nigeria, they have rhabdomyosarcoma followed by the lymphoma. The India is the lymphoma and nephroblastoma. Of note that I didn't include on this slide, in the USA, they see more of neuroblastoma followed by the nephroblastoma. So the survival rate of our patients was favorable, shows a very favorable prognosis. Completed tumor excision about 95%. We had a post-operative complications of about 1.9% with zero mortality in the period of 30 days. So in the conclusion, the review demonstrated that the burden of cancer seen in our community and capability of pediatric surgery department to safely manage broad range of solid tumors. Despite the limitation of resources and the referral networks, early surgical outcomes are comparable to the national benchmarks. These findings underscore the need of continued investment in our pediatric surgical infrastructure and multidisciplinary oncology care in our under-resourced. So our limitations, it's just we had the nationally poor record keeping and also being able to balance the clinical work with the research. I would like to thank all my supervisors for allowing me this opportunity to do the study, Professor Chiflaro, Dr. Mashaba, Dr. Mazombe, and my colleagues out there just to help me when we were doing the study to cover us up with the clinical work. So I thank you all.
Questions, please? Yes. Prof. Lotto, yes?
Yes. Thank you for the presentation. Can we look at the causes, the common causes of these solid tumor in this population? What are the common causes of it? And what is the difference in terms of the population? Where do we see them more? Is it in Capricorn or in the Vembe district? And why? Thank you.
Thank you very much for the question. So the next study that we're going to do is to look into what are the main causes of this condition, of these tumors that we see in Limpopo, and also we're planning on, we know that the areas where these tumors come from. We were going to go back to do a study as to whether what are the problems or what are the causes of all these tumors. The main ones that we see are mainly from Vembe, which will be our first target when we do another study to follow up as to whether what could be the causes, what could be the issues with the areas that these tumors are coming from. I hope I answered your question, Prof.
Okay, the why. It's fine. Okay.
Okay. Yes.
Thank you, Doc, for giving us the presentation on the patterns and outcomes of pediatric solid tumors. That was a wonderful topic. It is groundbreaking. And I believe that you have used literature review to strengthen your study, right? So here's my question. What literature review gaps did you notice while reviewing the studies in order to support your current study?
So in literature, we noticed that there are not a lot of studies that have been done on these pediatric tumors. I think we might have seen a few of them being done, but some of them they are not. We still need to push more into doing more research into this pediatric tumors that have been that we see, because there's no enough literature to review that we used. That's why we only have few areas where we can compare. It shows that nationally we haven't really been doing a lot of this kind of studies.
Okay, thank you very much. Thank you very much, Doc, for such a wonderful presentation. I just want to find out, how did you determine your sample size? Because I guess you were reviewing the records and 1, 2, 3, 4 as you were talking. And then the other issue is, I wanted to get clarity on this one. The age range of peds, was it until 14 years, or just a clarity seeking question on that one? Then I think, thank you very much.
Okay, I'll start with the age. In our oncology department, if we diagnose you while you are still within the pediatric community, we follow you up until maybe 16, 17. That's why you find that there are some who are going to be 14, there are some who are going to be 15. We don't just, now that because you are 13, we stop following you up. We follow you up in terms of recurrence. Remember, we've been in oncology. We start you from that pediatric. You're still our patient. We'll keep on following you up until we hand over to the adult ones. And I didn't know the other question.
The other question I can answer for you. He was asking about the sample size, and you have said it was a retrospective study for a year.
Yes.
So you had to look at what you have there. So there's no sample size there. Thank you. But I want to ask you, you mentioned an important conclusion here, the issue of resources challenge. So what are the resources which you will need, which was going to assist you? Because that's what I will want you to present next on the 29th, when Professor Tobeka Tusi and Professor Mike Seteke are here. They've got the money from the Medical Research Council. That's why you see them going up and down. Now, when they come here, so that they don't leave with that money, this money must remain. And it is only us who must tell them that this is what you need, so that we can get, yes.
So the first issue that we have, it's the staffing. We are really severely understaffed.
Right.
The second,
human resource.
The human resource, capital, yes.
Yeah.
Then we also need, we also struggle with our space.
Okay,
yes. Infrastructure.
Right.
We also, I would like to, for my boss to just, if you allow, for him to, my supervisor to add some
No,
more
the
stuff.
supervisor is done his part. We want you. What about the issue of the chemotherapy? Are you not having any challenge with that? Because theranostics and chemotherapy?
Chemopods.
Okay. Yeah, no, we also need for our patients, because we're going to be giving them a lot of chemo, and for a very long time, we need what we call the chemopods. Yeah, and also Broviax for the young ones.
So you need to write that, extend this presentation and put the challenges which we have, both the infrastructure, human capital, the medicinal, the chemotherapy, so that they know. It's a very good study. I'm just, well, there's an answer to why there's a predominance of maybe because the broom is there, that side. Okay. Thank you.
Okay, thank you very much.
Wonderful.
Thank you.
All right. Our next presenter is Matupa T, who will tell us about the crocodile bite injuries in the rural South Africa, a pediatric case requiring complex reconstruction. Yeah, assistant. Welcome, sir.
Thank you, Prof. Yes. Okay, good morning. My name is Tumelo. I'm a registrar in pediatric surgery with special interest in minimal access surgery and then also pediatric trauma. So I'm going to present a rare case that we have seen in our unit and then also treated. So that's a case about crocodile injuries. So if you go to the literature, you'll realize that crocodile injuries are usually uncommon, but also they present with a significant amount of trauma. And the injuries often, they are so extensive to the soft tissue, and then also they present with contamination. And often they require complex tissue reconstruction. So, but crocodile bites are rare in pediatrics, but potentially life-threatening. And they've got a because of the anatomical and also the physiology of the pediatrics population. But there is still limited literature with regards to their management, but also they require early multidisciplinary approach to have better outcomes. So presenting a case study of an 8-year-old male patient who was referred to us from Vembe district. So from the primary care, we got in a history that he sustained multiple gloving injuries secondary to a crocodile bite. So the injuries mostly was at the back, the perineum, and then also the lower limbs. So he was resuscitated according to the ATLS protocol. And then after that, we addressed them, we guided them in terms of wound care and then analgesia, and also make sure that the child has got broad-spectrum antibiotics, fluids, and also give tetanus toxoid. So the child was transferred to us for primary care. And this is the child, when the child arrived in Mangwing, in theater. So you can actually realize that the child has got like avulsion injuries and also multiple lacerations, mostly at the back and also at the perineum. So he was reconstructed by our team and also our plastic surgery team. But the patient did very well under our care until the child was discharged home and also came back for follow-up. So when we went to the literature, we have realized that in Limpopo province, there is about 23 patients, pediatric patients from the age of, between the age of 0 to 9 years. This is a study which was done between 1984 and then also to 2014. So, but then also, Asvin et al. Reported that the crocodile bites are often usually due to the animal defending itself, or maybe it has mistaken person maybe being a prey. But then most of the attacks, they tend to occur mostly during summer, and then the month where it occurs usually is October and April. And usually because they usually say it's usually Sunday time where most of the families are out and they are having maybe a braai next to the river. And the reason why it occurs during these months is because of usually this is the mating season for the crocodiles. There is several normal floras of the crocodiles which have been reported in the literature, which includes the Vibrio species, Cetrobacter, and then Pantonia, and then also the Bacteroides teres, and also the Clostridium, and Serratia, and also Pseudomonas aeruginosa, and also the Protea species. But most of injuries commonly affect the extremities, and then usually they present with fractures and then also soft tissue avulsion. And usually they say the mortality is mostly related to the injuries the patient might have sustained, and also sometimes a victim being pulled underwater. So from the discussion, you realize that our patient was actually sustained these injuries when he was swimming with his friends, because also they mentioned that, you know, crocodiles, they become more interested to the noise. So when they hear noise, that's when they come closer. But also our patient managed to escape and then was able to seek help. And then also on arrival at the local and also in our care, received a proper resuscitation. He was given broad spectrum antibiotics, and then he underwent extensive reconstruction surgery and then received a good postoperative care. However, there is limitation in terms of the pre-operative and then also intraoperative wound subs, which I think we should have done to see what we might have cultured on his wounds. So there is 2 crocodiles which have been reported. The 2 species. In general, we have about 23 species of crocodiles, but there is one which is commonly in South Africa, and that is the Nile crocodile, which is the one which is mostly responsible for attacks on human. And it grows about 5 meters. It has got about 68 teeth and accelerates about 20 kilometers per hour. So usually the crocodiles, they travel at night, and that's usually when they hunt. Yeah, they mostly hunt at night. But then also what has been reported is the fact that they've got a good sense. So they can hear, usually by the time you see them, they've already seen you. And also they don't get frightened by noise. And they are potentially dangerous activities, which includes fishing, fetching of water, and washing laundry next to the river or lakes, and also swimming, and then also crossing rivers. Those are usually the activities that prone humans to these crocodile bites. So in terms of our conclusion, crocodiles bites usually cause high energy trauma to the extremities, the trunk, and also the heads. And like I've highlighted, some of the patients that will present with fractures. And these injuries in pediatrics tend to be fatal, and then those that survive require prompt multidisciplinary approach, early surgical intervention, and then also tailored reconstruction strategies. So we need to make sure there is awareness and also preparedness in terms of the endemic regions that actually contains these crocodiles. In terms of the prevention, I think the most important thing with regards to crocodile is to make sure there's environmental awareness, safe behavior, and then also community infrastructure. And then also we need to make sure that we protect the livestock, because usually the crocodiles that will prey on these animals. And then we should also have emergency preparedness. So I would like to acknowledge my consultants and then also the plastic and reconstruction team. Thank you so much.
Let's find out if there are questions before myself. Hello? Any questions? All right, let me ask you now. Now, first, the human being to the crocodile is a prey. Yeah, so it is not mistaken. You go in there where the crocodile, you are going to be a meat. Why this kid was, what was happening? What was the kid doing there in the water? Where the crocodile? Was he swimming or?
Yeah, so what happens was they went to a river as a group of, so he was with his friends. Okay. So they were swimming. Unfortunately, they didn't know that river, there were crocodiles. So it looks like he was attacked by this crocodile, but he managed to escape. That is the good thing about it.
I see. In your presentation, you have outlined the contaminant, especially the bacterial types there. What is the significance you want to tell us about those type of bacteria? Are there ones, or some of them who are associated with causing like fasciitis and all this? To note the fact that after being bitten by a crocodile, you're going to get severe bone injuries, and it's a known fact. That's what it does. But the crocodile, the bacterial types, or the organisms, what is the significance?
Yeah, so the significance of highlighting the normal flora of the crocodile, especially with regards to this special case that we have seen. So some of the injuries that I've mentioned were on the perineum. So those are notorious injuries because you need to treat them with caution, having that fact that if you're not aware of the But the microbiology of these crocodiles, some of the patients might end up with necrotizing soft tissue infection, yes, which is devastating and also difficult to treat.
Which one of those?
So the Clostridium that I've mentioned is the most notorious one.
Is it amenable to our available antibiotics, or it needs a very set of fourth generations?
Yeah, so it's amenable to some of the species, but what we have done basically with the injuries on the perineum, what we did, we went in, we repaired the ones on the posterior aspect. We debrided the ones on the perineum, and then we came back 24 hours later to reconstruct these ones on the perineum.
Now, so what is the last message you would be telling the guys there in Bambi?
They need to avoid swimming in the
Yes, you can even tell them in Venda. There's a song of one guy, he said, Songotamba no Yaluma. This is the same thing.
Yeah, thanks.
Thank you very much, Chief.
There's another question. Chair?
Chair, yes.
There's a question.
Oh, there's a question? Yes. Sorry.
Thank you for the presentation. I take it as a case study, if we all in agreement.
Yes.
I would want to maybe to understand if, although these bites are rare, can we, maybe as we go in this research, come to a case series study where you can have many cases, and then you can see how are the patterns of the bite, and also what are the dangers that each bite will present in case you have more than this. I don't know if you thought about that.
Yeah, well, thank you for the comment. Yeah, because, I think the good thing is pediatric surgical unit is only one in Limpopo. So most of these patients, especially the pediatric population, will present to us. So the more we have this, is the more that we'll write about them.
Now in the past 10 years, you presented from 19 something
14, yes. Yes. But the, yes.
So now in the past 11 years, what is the situation?
Yeah, so the challenge is in the past 11 years, we didn't have a pediatric surgical department in Limpopo. It only started in 2019 to exist in the province. So that's why we don't have all these case series of these patients with crocodile bites. So, but we only have one now.
In the past 5 years.
So only have one. Yes.
The rest of the other, which were beaten, they have disappeared into the water. Thank you, sir.
Okay, thank you for the answers. Thanks.
All right. Our next presenter is Mavunda Domazi, NC, who's going to present anatomy of the common fascial vein in neonatal cadavers for parenteral feeding. Welcome. This is nice. These areas of research are very interesting. I like it. We are moving. We are doing very wonderful things. Yes. Welcome.
Good morning, everyone. I hope everyone is well. I'm Nsuku Mabunda Dumazi, and I will be presenting the research project titled The Anatomy of the Common Facial Vein and its Relation to the Cricoid Cartilage in Neonatal Cadavers. All right, so in the year 2000, UNICEF and the World Health Organizations reported that there were over 20 million births worldwide. And of those 20 million births, 15.5% of them were babies born with a low birth weight. And within that 15.5%, 95% of those children were born in developing countries with a low birth weight. Low birth weight is classified as a birth, the weight of the child, when the child is born with a birth weight of less than 2.5 kilograms. With low birth weight infants, they tend to have poor gastroduodenal coordination, and they also have 0 to none motor activity in their gastroduodenal tract. So what tends to happen because of the two above mentioned reasons, feeding of these patients orally is practically quite impossible. And so what happens is they are fed through a venous catheter, using obviously intravenously. And within the pediatric patient, essentially, they tend to use the internal jugular vein as the common site of insertion for the venous catheter, for essentially, obviously, the children to get the nutrients that they need in order to get out of this low birth weight. And what technique that they usually use is the open surgical cut-down technique in order to insert this venous catheter. But this does come up with some complications, especially in regard to the internal jugular vein. What tends to happen at the end of the procedure is the vein is then ligated, and this may cause problems in the normal circulatory flows and also does cancel out the vein for future venous catheter insertions. So with these complications that were presented, Zumbro et al. In 1971 presented an alternative catheter site insertion, which was the common facial vein. But very little research was done after he announced that we could use this site for catheter insertion. The common facial vein is a very small, it's a thick little vein that is formed by the union of the facial vein anteriorly and the anterior division of the retromandibular vein posteriorly at the angle of the mandible, and it will drain directly into the internal jugular vein. Lying close to this common facial vein are two nerves. The nerves, they are branches of the cranial nerve number 7, the facial nerve. The last two terminal branches, they being the cervical branch as well as the marginal mandibular branch. And since they're lying in very close relation to the common facial vein, we should be taking it into consideration when the insertion is made in order to insert the venous catheter. The aim of this study was to study the anatomy of the common facial vein as well as its relation to the two nerves, and to see the two nerves, the marginal mandibular as well as the cervical, to determine whether its position and morphology could be possible to make it a suitable alternative catheter insertion for TPN in neonates, right? So should this be the case, that we find that it is suitable, then how do we pinpoint it or locate it using surface anatomy? And we decided that then we should observe its relation to the common facial, to the cricoid cartilage, and to determine if we can use, how we can use the cricoid cartilage as a surface anatomy landmark to identify specifically the origin. So this study was conducted at the University of Pretoria at the Department of Anatomy, where the left and right sides of 24 neonatal cadavers that were less than 24 weeks with a very low to normal birth weight were dissected. Any neonatal cadavers that had abnormalities in the neck, developmental abnormalities in the neck region, as well as having previous dissections within the neck region, were excluded. All of these measurements were taken using the mechanical dial caliper with an accuracy of 0.1 millimeters. Right, so to expose the left and the right sides of the neonatal cadavers, the cadaver was laid in a supine position with its head rotated superiorly with the also rotated in a contralateral position so we can see the sternocleidomastoid muscle contracted. The skin was then reflected from the midline all the way to the anterior border of the trapezius muscle. The skin, as well as the platysma muscle, the skin, the fascia and all the tissue and the fat that was around the region was removed, and sternocleidomastoid muscle was cleaned and properly identified. Once that occurred, we then used blunt dissection to lift up the sternocleidomastoid muscle in order to identify the internal jugular vein. Once the internal jugular vein was identified, then we could easily then identify the common facial vein as well. So then the origin of the common facial vein, where its union between the facial and the retromandibular vein made, was pinned, as well as the termination. The origin was labeled point A and the termination was labeled point B. The first measurement that we took was from point A to point B to determine the length of the common facial vein. Then we then looked for the marginal mandibular branch and the cervical branch. The first one that we found was the marginal mandibular. It was pinned and it was labeled point C. Then the shortest distance from point A, which is the origin of the common facial vein, to point C was measured. Then the cervical branch of the facial nerve was then identified, pinned, as well, then labeled point D. Then the shortest distance between point A and point D was then measured. Right. Then now, when it was all done, we went into the midline of the neck, and once we got to the midline of the neck, we found the cricoid cartilage. When we found the cricoid cartilage, we are using the anterior lamina of the cricoid cartilage, we pinned that point and we labeled it point E. In order to determine its relation with the origin of the common facial vein and its termination of the common facial vein, we then put a ruler across from point E all the way to the anterior border of the sternocleidomastoid muscle. From there, we then took we then measured and compared its relation is whether the origin of the common facial vein and the termination of the common facial vein were found below or above the cricoid cartilage. Standing at the level or being at the level of the cricoid cartilage was labeled as either being 0.5 milliliters above or below the horizontal line from point E. This gave a room of error, right? Then what we did is then now to determine how we can also use the landmarks to determine if we can see the cricoid cartilage and the relation to the common facial vein, we then took that point here between the horizontal line and the anterior border of the sternocleidomastoid muscle, and we labeled that point F. Then going all the way up, we then took another ruler from point A to the anterior border of the sternocleidomastoid muscle horizontally. We labeled that point G. Going from point F to point G, we calculated that, we measured that distance and also measured the distance between point A and point G. All right? So obviously the statistics were made, the descriptive stats, we did the mean, the standard deviation, median, we did a PET test, we did the Pearson correlation test as well, and then we also did inter and intra-observer errors using the ICC values to determine repeatability and reliability of all the measurements. All right, so when coming to the results, the PET test showed no significant differences between the left and right side. Thus, we could combine the left and right sides, giving us a common sample size of 53. When in that 53, we also observed the formations of the common facial vein, as they do vary. In 83% of it, it was normal. 9% of them, there was no common facial vein because the facial vein and the retromandibular vein drained directly into the internal jugular vein. And in 8% of it, it did not drain into the internal jugular vein, it drained into the brachiocephalic vein, right? Then with the marginal mandibular and the cervical branch, its relation, whether it was superior or inferior to it, with the marginal mandibular, only 5% were found inferior and 95% were found superior. Right? With the cervical branch, 59% of them were found inferior and 29% of them were found superior, and with 12% of them found crossing the origin of the common facial vein. All right? Okay, so Now, when it comes to the stats of these, the distance from point A to point B, the mean average was 8.3, was essentially the length of the common facial vein with a standard deviation of 4.3. When it comes to the mean length of the shortest distance between the origin of the common facial vein and the marginal mandibular branch, the mean length was 6.6 with a standard deviation of 4.6. When it comes to the shortest distance between the origin and the cervical branch, the mean length was 4.6 with a standard deviation of 3.0. And when it comes to the diameter of the facial vein, the mean was 1.6 millimeters and with a standard deviation of 4.7. When it comes to the ICC values to determine repeatability and reliability of the measurements, they were all found to be within excellent range, with the exception of the highlighted ones, which were found within a moderate repeatability. And when it came to the intra-observer ICC values, they were all excellent with the exception of the two highlighted, which were then found to be more moderate instead of excellent for reliability. All right, so in the discussion, as we discussed, low birth weight can be caused, as the previous speaker also spoke, preterm birth, and can be also caused by restricted fetal growth. That is usually caused by poor maternal feeding, and that obviously then causes the baby to be born and with low birth weight, and then we do the TPN, and then there's a disturbance in circulatory flow, and that's why Zumbro proposed this technique. But Zumbro had also adapted this technique from another writer, which was Prudence, but Prudence was using his technique for ventricular shunting to relieve internal hydrocephalus. When he took it, he adapted it and used two modifications where the common facial vein was used, and also the type of catheter that was used was the Prudence ciliatic atrial catheter. Zumbro reported in his article that this technique that he adopted and adapted was a success on his infant sample. But his location of the common facial vein, he mostly used an insertion on the sternocleidomastoid muscle. When it comes to our study, to conclude the findings, we also saw that one of the closest lying veins between the cervical branch and the marginal mandibular branch was the cervical branch. But what tends to happen is the cervical branch, innervates platysma muscle. And if damage to that nerve occurs, there is only temporary paralysis, so it's not much of a big concern. The bigger concern was the marginal mandibular, although none of them were crossing the origin. It innervates the lower chin, the muscles of facial expression below the chin, below the lower lip as well as the chin. And so if that nerve is damaged, then there will be a drooping of the lower face. And obviously that is not a sight to see, especially in a neonate that's gonna grow up, all right? So what we found is we need to be, although they doesn't cross, but there were distances that was as short as 2 millimeters from the origin of the common facial vein, which then makes it, a very close vein to look, a nerve to look for when you're looking to insert, all right? So then when it comes to the cricoid cartilage, all right, we know that the cricoid cartilage is the only complete ring in the respiratory tract. It's part of the laryngeal skeleton. The cricoid cartilage at birth will lie at the level of C4, and in adults and us it will lie at the level of C6. The cricoid cartilage can be found through palpation in anyone. What needs to happen is the patient needs to just extend their head as far as possible. Then they will find the laryngeal prominence. Once the laryngeal prominence is found, below it lies the cricoid cartilage. Right. So many studies have used the cricoid cartilage to identify the internal jugular vein. That's why in this study we have adapted it to find the common facial vein, right? The origin of the common facial vein was never found at the level of the cricoid cartilage. It was always superior to it. Whereas the termination, 74% of them were found at the level of the cricoid cartilage. But what we're looking for is mainly the origin. So this is how we adapted to finding it. After identifying and palpating, after identifying the cricoid cartilage through palpation, right, the patient must then be put in a supine position.
Thank you, ma'am. It's time up. 15 minutes all used up. Thank you.
Thank you.
No questions, Chair. It's time up, sir.
Thank you. The only question is the ethics of who gave the permission to the
To dissect.
yeah, these babies. Thank you.
The ethics team of the University of Pretoria. The ethics committee.
Were these unclaimed bodies or what?
Yes, these were unclaimed bodies, babies that were found abandoned, because Gezina is a heavy drug place where a lot of babies are abandoned. And then secondly, we are allowed to go into the hospital and ask the mothers after yes, when you have a project like this to say, can I please? Yes.
Okay, thank you. That's an answer. Thank you very much.
Thank you, Prof.
Okay, wonderful. Thanks. And the last one is partial eye, who will come and give us the spectrum of disease admissions for general pediatric surgery, practice at Mankweng Academic Hospital in Limpopo, South Africa. A 12-month retrospective review. And then after that, we'll go for poster view. Thank you. Welcome. Thank you.
Greetings, everyone. I'll be presenting Spectrum of Diseases, Admissions for General Pediatric Surgery in Mankweng Academic Hospital. Limpopo, Limpopo province, it is located in the northeastern of South Africa, and it occupies about 10.3% of the country's land. And it has an estimated population of 5.78 million of people, according to the 2024 mid-year population estimation of South Africa. And with a youthful demographic, which is 1/3 of the children that are under 15 years of age, which this is the people we serve as pediatric surgeons. So in Mankweng Hospital, or rather Mankweng Hospital, it forms part of Polokwane and Mankweng Hospital Complex, which functions as a sole dedicated pediatric surgery in Limpopo, and it serves about all 34 districts and 4 regional hospitals across the province. This surgical department only has 3 high care beds and 15 inpatient beds in the pediatric surgical ward, not counting the neonatal one. So we are looking at pediatric surgical condition, and the pediatric surgical condition contributes significantly to the surgical disease burden in the low and middle class income countries, and also it contributes significantly into the morbidity and mortality of it. So understanding the spectrum of these diseases is essential for resource allocation, training, and planning appropriate interventions. So we find that there is a lack of data in Limpopo province. So this study aimed to review and describe the spectrum of pediatric surgical admission over the period of 1 year at Mankweng Academic Hospital to close this gap. How did we do the study? It was a retrospective observational study that was done in the Department of Pediatric Surgery in Mankweng Hospital through a period of 1 year from the 1st of March 2024 to 28th of February 2025. So a consecutive convenience sampling method was adopted, where all patients admitted during this study form part of it. So there was only a single researcher who adopted this information from admission registrars of the department and department database, and also patient files. Consent was not required, as this is a retrospective study, like I said before. So included patients were all patients that were admitted in the ped surgical ward during the study period, and those that were within the age of 1 month, between 1 month and 13 years of age. So we excluded all neonates, patients that were seen in was seen, or 4 other departments like plastic surgery, pediatric patients that were treated in Polokwane Hospital and oncology, and patients seen and treated in pediatric surgical outpatient department or outreach, not all. So patient who had incomplete data as well. The data that was collected is the age, gender, referring hospital diagnosis, if the admission was elective or emergency, the number or the length of hospital stay, the management that was done, if it was operative or non-operative, mortality, and the outcome of the results on discharge. So we had a total of 3,000, sorry. We had a total of 3,425 that were screened. And on the side and in the box, we show the numbers that were excluded according to each category. And we ended up with a sample of 830 patients that met inclusion criteria. And we found out that the mean age is 4 years old, with the gender, males composing of 59% of them, and females 41%. So on where this patient come from, we saw that most of the patient comes from Capricorn District, which is 210, and Mopani District followed next with 200, and Vemba District followed with 165, Sekhukhune District with 140, and Waterberg with 115. The spectrum, or rather the conditions that we saw in our department, we tried to categorize them according to category, because there were going to be many to be put on this slide. So we categorized them into gastrointestinal related, congenital malformation, infections, and trauma-related injuries, and mass and cyst. So we found that gastrointestinal related diseases were the most dominant one that we had in our department, which those ones are all types of appendicitis, all types of hernias, intussusception, Hirschsprung diseases, and bowel obstructions as well. Under congenital anomalies, we had anorectal malformations, undescended testes, hypospadias, biliary atresia, and tracheoesophageal fistulas. In infections, we have abscesses, surgical wound sepsis, cellulitis, mesenteric adenitis, and necrotizing fasciitis. In trauma, we heard foreign body ingestion, snake bites, corrosive or acoustic ingestion, and polytrauma as well. So in masses and cystic, we had vascular or lymphatic malformation, thyrocloisal cyst and ovarian cyst, renal cyst, and nephroblastomas as well. So most of our admissions were emergency admissions, which comprised 70% of it, and 30% of it were elective admissions. So the patient stayed for an average of 5 days in the hospital, and 88% of those patients were discharged well, and we only had 2% of mortality, unfortunately, and we referred the others 10% to for specialized care in other hospitals. In a discussion, we see that Mankweng has 830 patients over 1 year, compared to other studies or literature. We see that it's a smaller amount, but that's mainly because we excluded neonates, and other patients were not reported, as those patients are seen in casualty and be discharged like foreign bodies who ingested coins, and most literatures included all those patients. Also that we had this patient, some of them are polytrauma patients that are being seen in Polokwane, but by us, so we excluded them in this one. So gender-related, we see the predominance in male just mainly because, and it corresponds with the literature just mainly because there are more congenital anomalies that exist mostly in male than females. On diagnosis, we see most of GIT in comparison to what others see, they see sepsis and burns, but as burns are seen by plastic surgeries and trauma are seen in Polokwane, and we had relation with the Pakistan study that they see the same as us. So on admissions, we see that most are seeing mostly emergencies, but we try to balance the emergency and elective list as well. So the length is in between the literature as well, 5 days, and they have 3 days and 6.5. Mortality is 2%, and in Prince, in KZN, they had 0.2, but our mortality is still within the low and middle class income country average. So the limitation that we had is that we had missing and incomplete data that might skew a little bit, or the analysis and the balance between clinical work and research as well, because we were short-staffed. But as a conclusion, we see that the leading cause in our admissions is GI-related diseases, and we think implementation of preventative measures and early diagnosis will really take a lot of significance in having effective perioperative care. So better resource planning and training of healthcare professionals as well will help in managing these patients. So I would like to acknowledge my mentors and the nursing staff that helped with noting all the admissions and the permission from the hospital for us to access the records. This is our team that did their good work. I thank you.
Questions, please? And clarifications? All right. What was the associated underlying etiology for these many cases of gastrointestinal pathology, as you have indicated, the dominant one?
Appendicitis was one.
That's infective?
Yes.
The other ones?
The other one was because hernia, they do usually describe it into congenital as well, but I would say Hirschsprung's and intersusception.
Okay. Was there nothing related to one activity which we all grew up, they were doing for us, the spading and all this?
Intersusception could be one.
It could be one.
Yes.
So you need to put it there because it gives you an opportunity to educate the public, to know about the good and the bad of these things. Okay. Thank you very much. It seems like the hippie, but that's a very good study. A lot of work going on in that department. We are pleased and happy. Thank you. Please come and direct me what is the next thing to do. We done. Yeah. Huh? Oh, next one. So me, I'm off. All right, because I'm sure the Vice Chancellor is trying to find out whether I've resigned or not. If he's not seeing me in that.
Prof. Mamorobo, it's your turn.
afternoon. For this session, I'm Pamela Mamokgobo. I'll be facilitating the session. We have 4 presentations, and I'm not sure as to whether all of them are here, but I know Prof. Mutelo is around. And the first presentation will be on adaptation of theory to change framework in the development of impactful objectives in maternal nutritional preventions in rural settings, South Africa. It's dark here, I can't see. I'm not sure as to whether the other one will see. Is there anybody to help us with the lights here? Prof. Mutelo? Prof. Mutelo is not there, but she was around. So we can have the next one. Can I have light? We're not, it's dark here. I want to have the light on. Should I increase? Can we give a lamp? Maybe we should increase there. So the next one, okay. Is Prof. Mutelo there? If Prof. Mutelo is not there, can we have the second presenter, who is Muraswi. Muraswi will be presenting on appendicitis. It's in a neonate, a diagnostic challenge. Hey, my eyesight is terrible.
Good morning, everyone. I'm Dr. Murasi from the Mangoing Hospital Pediatric Surgery Department. I'll be presenting today on neonatal appendicitis. So this neonatal appendicitis is an extremely rare surgical condition, mainly due to the difference in anatomy of the appendix in the neonates compared to what we have in the older children. So in the neonates, we have this funnel-shaped base of the appendix, therefore making the luminal obstruction very difficult, which is mainly the pathophysiology in the older children. So today I'll present 2 cases. The first being a day 6 of life, IVD exposed neonate on prophylaxis, born at 33 weeks of gestational age with a birth weight of 2.4 kilograms, presented now with abdominal distension and irritability. So on examination, this neonate was tachycardic with a multi-distended abdomen with an erythematous discoloration of the abdomen with visible superficial veins on the abdomen. So the baby was slightly tender on the right iliac fossa, but was not peritonitic. So we obviously investigated the child, of which the blood showed that the neonate had a raised CRP and a neutropenia of 2.9. So we did an X-ray. The X-ray which showed multi-distended stomach with some distended loops of bowels, but didn't have any signs of NEC or any signs of perforation. So we initially managed the patient conservatively with IV antibiotics and serial abdominal examinations. However, the abdominal distension worsened and the erythema increased. So we decided to take the child for explorative laparotomy. Intra-op, we found that the child had a ruptured appendix with a purulent abdominal fluid, and an appendectomy was done. The histology was then followed up, which showed that the child had an acute suppurative appendicitis, which was associated with with a serositis, which was confirmed. There were no granulomatous granulomatous inflammation, and there was no signs of malignancy. The second case was a day 3 of life, also born at 33 weeks gestational age with a birth weight of 2.2 kilometers, born to a type 1 diabetes on insulin. Just hold on, I'm just having... Yeah, on insulin, was born preterm due to the fact that the mother had a pre-labor, pre-rupture of membrane. The baby presented with respiratory distress and a distended abdomen, also had a raised inflammatory markers of raised CRP, raised white cell count. The x-rays showed again a distended stomach, also with some signs of pneumoperitoneum. So this patient was then taken for an explorative laparoscopy, of which they found, again, a perforated appendix with intra-abdominal pus collection. And a laparoscopic appendectomy was done using a 3 times 3 millimeter port to do the appendectomy. So, again, the histology was followed up, which also showed that there was a suppurative necrotic appendix, with no neoplasm and no granulomatous inflammation. So both of these patients recovered very well and were both discharged on full feeds. So basically, like we said, neonatal appendicitis is very rare due to the shape of the base of the appendix and due to the fact that they have a liquid diet. And it's normally not identified unless if they have like complications such as peritonitis or they have perforation. So, and it's basically the diagnosis is usually intraoperative, and you need to have a high suspicion or index of suspicion, and basically in any surgical intervention is what you need to prevent morbidity and mortality. Thank you very much. I'd like to thank my department, Prof. Chifularo, Dr. Mazombe, Dr. Mashaba, and the rest of the team for helping me with this presentation.
So I think we'll ask questions after the both presentations.
Oh, the people already. Yeah.
Yeah. Good morning. Thank you for the wonderful study. But I wonder if I missed it. What research methodology did you use here?
So this is it's a case series. So it's basically we are reporting on the cases the rare cases that we have. It's not like it's a case series, basically. So we've only seen two cases since the start of the pediatric surgery department has started, and these 2 cases are the ones that are reported here currently.
Okay, thank you.
Also, to add on, so that people understand, these cases are very important in terms of creating publications, high impact publications, because in such a case you can present it or you can publish it in many different journals, the surgical journal, the pediatrics. But my question is, you said it's a diagnostic challenge. What else does it present or simulating an appendix? Because I didn't get that.
So it's like I said, because it's very rare, you think of all the other things first, and that's why we looked for, like I said, we look for NEC when these patients present like this. And the minute we don't find it, it becomes a challenge that what then is it? So that's why because we were not sure, we took the child for an explorative laparotomy, especially with the first case. Even with the second case, the child didn't have any signs of NEC, which is what we normally expect at this gestational age. But because of the pneumoperitoneum, we were forced to go into theater and operate, and only then did we realize, oh, it's actually an appendicitis. So both these cases didn't have any signs of what we normally expect at this age that causes peritonitis, but we found intraoperatively, like I said, it's normally an intraoperative diagnosis that it's an appendicitis, which is not common, and according to the pathophysiology, is very difficult to have in neonates because of the shape difference between the neonates and the older children.
So at the end, when you put everything, how will you help the next clinician to make sure that it doesn't miss an appendicitis?
Yes.
In the child?
So
because that's what you should be telling us and say, we're putting the following out as you're sure that in the future you will be making a diagnosis.
Yes. So like I
so
said,
that you will reduce the errors. Thank you.
So now that we have seen it so often, okay, not so often, the 2 cases that we have seen, we know that appendicitis should be in our differentials. It's not something that we must think it's far-fetched anymore. If you see a child with some form of peritonitis and you don't know what it is, it should be part of your differential. And like we said, early surgical intervention is better than us trying to treat medically like we tried the first time. And early surgical intervention is important. Look, go explore. You'd rather be safe than sorry.
Thank you. Based on the research, what are the most probable predisposing factors in this case?
That's quite interesting. It's a good question, and that's what I want to research on. In literature currently, it says that the most common things that cause the most common conditions that predisposes kids to appendicitis is Hirschsprung's disease. So kids who are known to who have Hirschsprung's disease are prone to neonatal appendicitis. Kids who have what is called like a small colon, left colon syndrome, like in this page, the second case, whose parents have are known diabetics, their colon tends to be smaller. So then it predisposes them to neonatal appendicitis. So or kids with cystic fibrosis, with thick mucus that is difficult to pass through the lumen of the colon, that also causes predisposes them to neonatal appendicitis.
Thank you so much. Sorry for intimidating Dr. Muraswi. We have somebody who is checking on time, so he'll keep on picking up something for you to be able to see how many minutes are left. So for now, I've seen Prof. Mutelo to come and present to us on So Prof. Mutelo will be presenting on adoption of theory of change framework in the development of contextualized objectives for maternal nutritional interventions in a rural setting of South Africa. Can we call those people so that we can display? Somebody to help with the...
This is the one, eh?
It's a poster.
Oh, it's a poster. Where's the thing now?
It's not sure. Maybe
It's,
it's show.
no, it does. It's a poster. Can you help us? Here it is. It's a poster, Maternal. This one. It's not opening. The next one. All right. While they're sorting out, let's give. Sorry, Prof. Yeah. Let's get Morasi. Oh, yeah, okay. Who's the next one? Petra. Bowel evisceration through umbilical hernia after hot water burn in a child. A rare case. Is Petra here? Petra?
He just went outside, Prof. He's coming back.
Okay.
We can do.
Lichava. Is Lichava here? Sigmoid volvulus in pediatrics, a case report and literature inside.
Petla is here.
Oh, it's here. Whoever is here. First come, first serve. Now they need to assist us. The presentations are not flashing on the board. So it looks like the. Oh, more? No, it's not. What computer is it? It's not the Apple.
It's not doing the doing. Yeah. But your duplicate doesn't work. No, it's that side. Or is that side? If it yeah, you can try. I can start, okay. Good morning, colleagues. My name is Solomon Petla, and today I'll be talking to you about a very rare case. It's a bowel evisceration following hot water burns in a child. So, abdominal wall eviscerations, they are commonly due to abdominal traumas, penetrating abdominal injuries, and less so due to blunt abdominal traumas and post-operative complications such as wound evisceration. So this spontaneous bowel evisceration through the umbilical hernia is an extremely rare case. So the patient that we had at our hospital, Mankweng, it was a 1 year, 6 months old female who sustained hot water burns that were 47% total body surface area, and then they were superficial partial thickness burns. So this happened after the child was playing, and then he fell into a bucket that was full of hot water. So this child we admitted to our hospital. And then we managed this child. We gave them fluids as per the protocol, and then we did the wound care, and then we also gave medicines. So of note, this child had a reducible umbilical hernia. So we took this child in for operation, and then we washed this bowel, and then we reduced it, and then also we fixed the hernia. And then after a short while, this child, unfortunately post-operatively, the child started to deteriorate, and then the child was also having sepsis, which led into shock, and then also this child had a suspected spontaneous pneumothorax. So unfortunately, this case resulted in a mortality. So Umbilical hernias are common in infants, but majority of them, they resolve spontaneously. And then also literature suggests that that the lifetime risk of umbilical hernia, incarceration and or strangulation, it's between 1 and 3%. Spontaneous rupture of umbilical hernia, which is a rare occurrence, has been reported as a complication of persistent ascites in the elderly, and then with an associated mortality of about 10 to 20% following surgical intervention. But there are no reported cases on umbilical hernia rupture in children complicated by bowel evisceration. We postulate that this complication was related to the depth extent of the burns on the abdominal wall. Due to lack of tissue at the umbilicus, full thickness injuries at the umbilicus are easily sustained, which can lead to a rupture. With such severe burns, evisceration compounded the mortality risk in this patient. So, as I conclude, I believe more research needs to be done with regards to the effect of hot water burns on the abdominal wall integrity. And then this can change the management of burns to the abdomen in patients with ventral hernias. And early surgical hernia repair might reduce the risk of evisceration in such patients, thereby improving the outcome. So I thank you. And then I'd love to acknowledge my seniors, the pediatric surgery team. Thank you so much.
Yeah. Can I ask a question?
Okay.
Yeah, thank you for your wonderful study. This is really a rare case, right? But you know what? I really missed your approach. Like, which one? Did you use a quali, a quanti, a mixed method, a multi-method? You know, what type of method did you use here?
So this is a case report. So we're just reporting on something rare that happened. It's not like a research where you do where you take numbers in and all that. We just report on something that's rare.
Oh, okay. Sure.
To avoid questions, when you present the case report, in your final analysis or conclusion, you must bring out the learning lessons of that condition to say, in this condition it's very rare, but not to miss it or to make sure that the diagnosis is, consider the following things. There must be something, it must not just be a case reported, but with learning points to say, for the next clinician, unless it is just a rare disease which is easy to diagnose, but being rare, you know, saying, look out for this thing. Sometimes it does happen.
Okay.
Yeah. So that's what case reports are for. They have a learning lessons to say, for future, not to miss the diagnosis, consider the following thing, just like this patient which presented with this and that. Thank you.
Thank you.
Thank you very much. We appreciate the report. Just on, I think we all agree that it's a quite a rare condition, but in terms of prevalence and incidences, what are the statistics? Thank you.
So on literature, there hasn't been a case where the child that was burnt by water and then the child had an umbilical hernia and it quickly ruptured. So we don't have that currently. Except for there's been umbilical ruptures that were reported in adults where a patient had ascites. But then this case, there's no literature that's known about this.
Thank you so much, sir, for the intellectually stimulating case report that you have just presented. Just out of curiosity, when you mentioned that that case was a rare case, it's something that has never happened before, when the child was burned by water and that part of the body ruptured. I wanted to check, I'm sorry, I'm not a medical doctor or a medical professional, I'm an economist.
do you guys in the health sciences do like thermal tolerance studies to sort of, since this is a rare case that has happened because of maybe the heat, the intense heat from the hot water, are there studies or that have been done on thermal tolerance, or is this something that you think could be investigated further? Thank you.
Okay. Okay, so this case, like I've said, there hasn't been any literature on it. So the reason being, when we brought this case up, is we want to actually further investigate if, do we have to really, for every case where there was a bends, do we really have to fix them before anything? So actually this is what prompted us to start this case. But otherwise, there hasn't been any literature that we know currently. So I think that's all. Thank you.
Thank you, sir.
So Prof. Mutelo will present without visual presentation. You will just talk over. Yeah.
Okay, good afternoon. Apologies, I don't know what's happening, but it's a poster. So I'm going to present a study titled Adoption of Theory of Change Framework in the Development of Contextualized Objectives for Maternal Nutritional Interventions in Rural Settings of South Africa. This study was done in collaboration with Dublin University College in Ireland, funded by the Irish government. So maybe you are asking yourself, why did we adopt a theory of change? Imagine being a pregnant woman, excited about giving birth, but yet you are in rural areas, you are faced with a lot of challenges. So the reason for this study is for us to develop the contextualized maternal nutritional intervention using the mHealth app. So why did we use the theory of change? Like any other study, the theory of change was used as a roadmap to develop evidence-based interventions or changes that will fit the the experiences of pregnant women who are in rural areas, who are faced with these challenges such as poor access, low socioeconomic affordability, the cultural practices, and those other ones. So, in summary, this theory of change is just a roadmap wherein before you conduct your study, you visualize, you have a vision that this study is going to be conducted where, who are our stakeholders, what will be the obstacles. So this framework was adopted to frame to develop the contextualized objectives so that at the end of the day, the study can have impact on the pregnant women who are in the rural areas. So globally, maternal and child nutrition remains a significant public health challenge, specifically in low middle income countries. Hence, the challenges of achieving zero hunger in maternal nutrition are multi-phased and include limited access to nutritious food, cultural practices that hinder a healthy dietary choices. Therefore, inadequate healthcare practices can also, inadequate healthcare access can affect the well-being of these pregnant women and their baby. So, the current study has adopted the theory of change framework to illustrate how and why desired changes maternal nutrition are expected to happen as a result of intervention. This is a poster, and I'm struggling to see the font, so you'll just bear with me. The font is too small. I thought they will display there, then I can see, because everything had to be in one slide. So the methodology we followed now this thing cannot move. Where is he? I want to move this. Okay, the aim of the study was to describe the development of the maternal intervention which were guided by the theory of change framework. Like I said, the theory of change is important, more especially when you want to develop, when you want to conduct a study which has got impact for sustainability and also for identifying your key stakeholders, your key communities. Like in this case, we have identified the policymakers, the farm workers, the farmers, the community leaders, the pregnant women, the people who are involved in digital health, and we have also identified through the theory of change. We have also identified the people who are responsible, like the societal impact champions, so that this intervention can be able to fit the context. And then the study adopted theory of change framework using the following 6 steps. This was done through the range of training and consultation with different stakeholders such as community leaders, equals to 20. We had 20 community leaders, agricultural scientists times 2, IT specialists times 1, societal impact champion 1, digital health center, HEB, the food technologies, the midwife, and the dietitians. So our results, after we've consulted with the we drafted the objectives for the study. After we drafted the objectives of the study, we had workshops wherein we had the consultation with these identified stakeholders. So, and then we, with the results, we validated those objectives, and then we added things like the issue of identifying the politicians. Remember, we are in a community wherein politics have got influence as well. And also they added that we must also add the traditional healers, because at the end of the day, these interventions, whatever they eat, they first go and consult with the traditional healers. So including the enabling factors, the outcomes, they categorized, we ended up having the short-term, the medium-term, and long-term goals. And then the most important thing when we do this research, we want to see the impact. What are the socio-economic impact, the social impact, impact on healthcare, impact on policy makers, the impact on reducing the maternal and child mortality. And then, in conclusion, the adoption of theory of change framework enhanced the development of impactful interventions and the maternal nutritional interventions that were grounded in the context-specific reality by ensuring that they are relevant to the socio-cultural and the environmental factors within the community. Thank you.
Thank you. You used up all the time, so we want time for questions.
Lichaba will be the next presenter. Sigmoid volvulus in pediatric case report.
Good afternoon, everyone. As Dave introduced me, my name is Dr. Lichaba. I'm pediatric surgeon from Mankweng Hospital. I'll be presenting sigmoid volvulus in pediatrics, I'll be presenting sigmoid volvulus in pediatrics, a case report which also is a very rare case. So sigmoid volvulus is an uncommon cause of abdominal pain and bowel obstruction in children. And in pediatrics, the most type of volvulus is related to malrotation and internal hernias. So with the case presentation or case report, we admitted a previously well 6-year-old male, or rather boy, who presented to us with a 2-week history of abdominal distension, vomiting, and also constipation. On examined, vitals were stable, and other systems were unremarkable. But however, on abdominal examination, it appeared to be a distended tenderness, tympanic on percussion, and also there were visible bowel loops. So the patient was then taken for an X-ray to investigate further as to rule out other causes of bowel distension. So we did an X-ray which showed a distended loop of the sigmoid colon, which showed a classic coffee bean sign. So patient was then taken to an emergency operation where we did an emergency laparotomy for bowel obstruction, where we found we confirmed a 360-degree twist of the sigmoid colon, which was consistent with the sigmoid volvulus, and there wasn't any evidence of bowel necrosis. So we did a detorsion sigmoidectomy, and we also did a colostomy, and we took biopsy. We took sigmoid biopsy and rectal biopsy just to exclude other causes of bowel distension. So from the biopsy, we sent the specimen for histology, which came out as from the sigmoid, there were serocytes, and also there was present ganglion cells, which excluded Hirschsprung's disease. So the other picture just showed the theater findings that we found in theater. So on discussion in Africa, adult sigmoid volvulus accounts for 50% of cases, but in pediatric sigmoid volvulus is a very rare condition. Its physiopathology or pathogenesis remains unclear, but there are predisposing factors like the anatomical factors, dietary factors, and also genetic factors. But other literature did suggest that there might be a colon rotation that around its mesentery, leading to a closed loop which traps the air, leading to that might lead to necrosis and further worsen the bowel then further increase the intraluminary pressure. So typically with this condition, we see them in between the ages of 7 and 12 years old, more in male than female, with a ratio of 5:1. So is more common, the most common types that we see are the midgut volvulus. We also have the cecal, transverse colon, and also the iliosigmoid volvulus. So clinically, when they come to our settings, they can present with an acute fulminant type where they have a sudden onset of abdominal pain, distension, nausea, and vomiting. And also that can also lead to vascular compromise. And if we don't diagnose it early, they can also progress to shock, and at 10, they can also demise. The other clinical presentation is they can present with chronic progression, like they have an intermittent abdominal pain, constipation, and due to spontaneous detorsion, they can also lead to shock, and later they demise. With the investigation, when they come to us, we do X-rays which confirm the classic coffee bean sign, and also we do enema and also CT scans, but we don't normally do CT scans as for the radiation exposure. So on management, they sometimes they might be stable with peritonitis, without peritonitis, and also unstable with peritonitis. But with these two, we treat them differently. So with stable without peritonitis, we do a non-operative decompression with a sigmoidoscopy and rectal tube, and also we do them with contrast enema. But the ones with unstable and peritonitis, we take them for emergency laparotomy, for sigmoidotomy, and also we do them a colostomy. So in conclusion, it is a very rare condition in our setting. Over this year, this is the only case we saw. In the past 10 years, there was only 0.65% of these cases that we saw. And we as clinicians, we advise everyone to, when they see the patient, they must exclude other causes. Hence, we do different investigations, and also to exclude other diseases that they might come with. And with our setting, we say that if we give them a lot of time, or rather, if we don't treat them immediately, they lead to shock, and also the patients might demise. Thank you so much. I would like to appreciate the help of my mentors, Prof. Chifularo, Dr. Mashaba, and Dr. Mazombe, and Pediatric team, and thank you, and the opportunity for the university to present. Thank you.
Thank you, ma'am. We have a space for only one question. One.
Thank you for the presentation. I think it was well presented. What I want to ask, which I didn't get in your presentation, is that this is a case report. And with case reports, there must be a special thing that comes out of that, because you cannot report each and every case that you meet. So in this, in your presentation, what made you to choose the case such that it is worth presenting? Thank you.
So thank you for the question. Like I said initially, that this is a very rare a case for our setting, as it has 0.6% of only patients that we see. And this presentation, it was the only patient that we saw from last year until this time. So for us, it was a very, very rare condition, and we hardly see this in our settings, hence we're presenting it.
Thank you.
Thanks.
Thank you. We are now moving to oral presentations, and I'm going to hand over to Dr. Sukati. Dr. Sukati. Thank you. Please remember to sign for the CPD both morning and afternoon session, especially those who are registered with councils. Session is this? No, we don't have the presentations for now. So these are the morning. Oh wait, I think here. Session 2.
because I know this one.
Oh, yeah, yeah. But this one is presenting now.
Damn.
Here, Mulambo.
Okay.
And then we have Mogabatlo. Sorry. And then Maribeng. Yes, Maribeng. Is there anyone? Khanyani, we don't have any from this group now. On the list there. Let's start with Malabo. Then I'll sort out the rest.
This is this one next. Greetings, ladies and gentlemen. I am Veli Sukati, will be chairing this session. Sorry for the delays. We're just checking if the presentations are loaded here. All right, without wasting time, we are not going to follow the program as is because we realized there is one presentation that we are not able to allocate. Can we have Molapo, who's going to be presenting antimicrobial status of adults on antiretroviral therapy attending clinics in Hamatlala, Limpopo Province, South Africa.
The first one, the first one. Good afternoon, everyone, and thank you for the opportunity to present. I am Manchela Molapo, and I am a registered dietitian stationed at Goedgevonden Clinic. I'll be presenting on anthropometric status of adults on antiretroviral therapy attending clinics in Ramatala, Limpopo Province. The initiation of antiretroviral therapy has shown a significant increase in life expectancy of this group. However, it has also shown increase in overweight patterns. And overweight patterns have risk factors of non-communicable diseases. So there is a need to investigate a comprehensive anthropometric status of people living with HIV. The study findings may serve as an important role to encourage health professionals to conduct anthropometric status for this group and also to intervene nutritionally if necessary. The purpose of the study was to assess anthropometric status of people living with HIV, and the first objective was to measure the anthropometric parameters such as body mass index, mid-upper arm circumference, skin fold thickness, and waist circumference. The second one was to calculate the percentage body fat, and the third one was to determine the relationship between anthropometric status with socio-demographic profiling. The approach that was followed was a descriptive cross-sectional quantitative research method, and it was done on population size of 871. The population was from Matlala Clinic and Maraba Clinic in Ramatlala village. The sample that was obtained was 220 of people living with HIV, which was 75% response, and it was obtained through random sampling method. Data was collected using a structured questionnaire to collect socio-demographic data.
during clinic visits, and the researcher was the one who measured anthropometric data, such as weight, height to get body mass index, mid-upper arm circumference, waist circumference, and also measured bicep, tricep, subscapular, and suprailiac measurements of the skin fold thickness to calculate percentage body fat. Data was analyzed through statistical package for the social sciences, version 29, and a chi-square test was performed for inferential statistics, and a p-value of less than 0.05 was done to signify the significance of variables, relationship between the variables. On results, social demographic results showed that most participants were females by 81.4%, and majority of the participants had secondary educational level by 76.3%, and most of the participants, which is 95.5%, were on regimen 1 of antiretroviral therapy, which contained dolutegravir, tenofovir, disoproxil, and lamivudine. And 80.5% of this group reported to adhere to medication, and the mean age was 43 years. On anthropometric assessment results, with body mass index, it showed that 53.2% of people living with HIV were either overweight or obese. And then through mid-upper arm circumference, 52.7% of the participants were obese, with 8% being overweight. Through waist circumference, the results showed that 45% of the participants were at high risk of non-communicable diseases. And with percentage body fat, participants showed that overweight was 25.5% and obese was 6.8%. With the correlation between sociodemographic profiling and anthropometric status, mid-upper arm circumference and percentage body fat was significantly associated with gender and the type of antiretroviral therapy. And also, waist circumference was significantly associated with gender and educational level. Body mass index was also significantly associated with gender, the antiretroviral therapy regimen, and educational level. In conclusion, a high number of people living with HIV showed that they were either obese or overweight. And the significant relationship with antiretroviral therapy was shown between either participants who had secondary education level, or if they were female participants, or if they were on regimen 1 of antiretroviral therapy. And these findings call for nutritional intervention for people living with HIV so that they can maintain a healthy percentage body fat. These are my references. Thank you.
Questions, please.
Well done there, Lady Malapo. I just wanted to check if you compare this plus what is in the community, the obesity in the community, Did you think the HIV was making a bigger impact or not?
Thank you for the question. With the place where I'm stationed, I had observed a high prevalence of overweight and obese. However, with the limitation of my study, there was no dietary intake to see if it also has an impact on these results. So I wouldn't have like a conclusion around that. So I think maybe in the future we can include dietary intake to see if can it also have an impact. But with what I have experienced, I think it does have an impact.
So it will be to compare the obesity or overweight problem in the community and then comparing it also with those patients that are on treatment to see. So I think that's where you should also look, because generally in the community now we are finding that people are overweight, obese. Is it really just a medication, or is this the pattern in that community?
Okay, let me ask two questions. One question is that when I look at your results, I only see normal, overweight, and obese. Are you saying that in the 871, especially from Matlalane?
Yes.
There's no one who's who's underweight, or are you saying that all, maybe as the last speaker indicated, is it a pattern that obesity is increasing in such a way that we don't have lean people? I think that's the first question. The second question, please ignore my ignorance. With the treatment, I think you have mentioned 3 or 4 drugs. Are they using them as individual drugs or in combination? And if it's individual drugs, the association that you got, were they related to a particular drug? Thank you.
Thank you for the questions. With underweight, certain anthropometric status showed a very small prevalence of underweight, like 8%, but with other anthropometry, there was no underweight at all. And then with the drugs, it was a combination with, like, for example, the one where a high number of people were on, it was regimen 1, so the 3 drugs were a combination that they were getting. I hope I answered the questions.
Any other question? We still have time. Going once, twice. Okay, yeah, there is Prof.
Hello. Could this overweight related to the retroviral or antiretroviral therapy side effects?
Sorry, please repeat the question.
The overweight, can it be associated to the HIV treatment side effects?
I'm not sure if I will be answering the question properly, but according to literature, the new drug that was introduced, it showed that it was more related to overweight and obese than the previous drugs. So I think with more research on it, I think I will focus on seeing if that is possible.
Yeah, thank you for your wonderful presentation. I just want to find out your target population. Was it both males and females, or who were actually having the same problem of overweight, or what?
Thank you. The target was both males and females. However, with the side of the research, more females were found, but we're targeting both.
Thank you. I think the presentation is quite interesting and thought-provoking. I just wanted to ask something, maybe in the follow-up to what Prof was asking, particularly on the overweight of this HIV cohort of patients. In terms of their diets, is it also the case that those people who are leading a healthy life, like eating properly, a healthy diet, exercising, but are also on that therapy for that new drug, are they also even getting overweight, even though they are, implementing other interventions to deal with the overweight?
Thank you for the question. I cannot really answer it directly because there was a limitation on this study where we didn't investigate the dietary intake and the physical activity, so we cannot really conclude on how much that can impact on the overweight and obese.
All right, thank you very much, Ms. Molapo. Our time is up. Okay, so the next presenter is Molewa, KG, Association between Visceral Obesity Changes and Hypertension over 5 years in Dimamo Health and Demographic Surveillance Site, Limpopo Province, South Africa.
Good afternoon. Greetings to the House with its greatest capacity. Standing before you is Mulawa Gift, and on behalf of my fellow group mates, I'll be presenting the study titled The Association Between Visceral Obesity Changes and Hypertension over 5 years in the Dimamo HDSS. Right. So hypertension is the leading cause of mortality, and according to the World Health Organization, it is defined as the blood pressure above 140 per 90 millimeter of mercury, and there is a prevalence of 31.5% in low and middle income countries and a 28.5% in high income countries. There are several factors that are linked to hypertension, and one of them is visceral obesity. And according to the World Health Organization, by definition, visceral obesity is defined as the fat accumulation in the abdominal cavity, and its prevalence in the sub-Saharan Africa is 37%, with South African women showing the highest rate at 42%. And recent studies in the Limpopo province reported a higher prevalence at 63%. And there are several studies that have already associated obesity and hypertension, and those that are available are cross-sectional and they are limited. Therefore, as a result, the aim of the study is then to determine the association of a 5-year change in the visceral obesity and its effect on hypertension among the elderly South African residents in the Dimamo HDSS. And the objectives were to determine the change in the visceral obesity over a 5-year change, to determine a change in the hypertension over a 5-year period, and to determine the relationship between the change in visceral obesity and hypertension, which then leads us to our research question: what is the association of a 5-year change in the visceral obesity and hypertension among the adult residents in the Dimamo HTSS Limpopo province in South Africa? Right, and the study design was retrospective and longitudinal as it used data from Augen phase 1 and phase 2, and the study took place in the Capricorn District Municipality of Limpopo province, and the study population included all the participants that were present in Augen phase 1 and phase 2, and the sampling method that was used was census sampling, and all the participants that participated in phase 1 and phase 2 were included in the present study, which form part of our inclusion criteria. And all the participants that did not have the required data, which was the systolic blood pressure, diastolic blood pressure, and waist circumference, they were excluded, which form part of our exclusion criteria. And the sample size was 291. And data that was collected was waist circumference, waist to hip ratio, systolic blood pressure, and diastolic blood pressure. And they were extracted using the extraction tool. And under the diagnostic criteria, the systolic blood pressure that was above or equal to 140 millimeter of mercury, and a diastolic blood pressure of 90 or more than 90 millimeter of mercury was diagnosed to be hypertensive. And men that have a waist circumference of 102 or more, and women with a waist circumference of 88 or more, were diagnosed with visceral obesity. And under data analysis, an SPSS version 29 was used, and the statistical tests that were used included the one-way ANOVA, which was used to analyze the relationship between the change in waist circumference and the change in systolic and diastolic blood pressure in the 5-year period. A chi-square test which was used to correlate the relationship between the change in waist circumference and hypertension, and a partial correlation which was used to assess the association in the change in waist circumference and a change in systolic, diastolic blood pressure and hypertension. And a p-value of less than or equal to 0.05 was used as a threshold to assess the level of significance. And under ethical considerations, we obtained approval from the TEFLOP Research Ethic Committee, and the permission was obtained from the Augen to use their data. And no consent was required since the study used secondary data. And the anonymity was ensured by using research identifiers, and confidentiality was ensured by signing confidentiality agreements. And maleficence, which refers to harm, didn't apply in this study since the study used secondary data and there was no interaction with participants. And in the results, it was observed that the prevalence of obesity was found to be higher in women as compared to men. And in terms of hypertension, participants that transitioned from being centrally obese in phase 1 to being normal in phase 2 showed no change in the prevalence of hypertension, and it was constant at 28.6%. And those that transitioned from being normal in phase 1 to being centrally obese in phase 2 had a significant prevalence change from 6.3% to 37.5%. So the study found a significant association between visceral obesity and hypertension, which is in agreement with other cross-sectional studies. And participants who transitioned from normal to centrally obese showed a significant increase in the hypertension. And the study found a positive and significant correlation between the changes in the waist circumference and hypertension, which is in agreement with other longitudinal studies. And the study concluded by showing that even in rural African populations, the change in visceral obesity is associated with the change in hypertension. And the limitations of the study: one, the sample size was not calculated, but it was based on the availability of purposive participants. And the study was unable to show a definite correlation between visceral obesity and hypertension. There were also more females than males, which potentially introduced bias. And the findings are limited due to the rural setting and can't be extended to urban populations. And the study then recommends that more longitudinal studies should be conducted in order to determine the relation of visceral obesity and hypertension. And the studies, those studies should also ensure that the sample size is appropriate for that study, and gender bias should also be addressed. And these were the references that were used. So, ladies and gentlemen, thank you.
Thank you for the presentation. Any questions? Let's have questions. Were we following? I don't see any hands. Oh, thank you.
All right. Thank you very much for such wonderful presentation. I just want to find out which or what kind of research identifiers did you use on the issue of anonymity?
Sorry, please repeat your question.
I'm saying, under anonymity, you said you used research identifiers. Yes. So I'm not sure if, maybe can you elaborate more or maybe clarify that, what kind of identifiers did you use?
Oh, thank you for the question. In terms of ensuring that your identity is anonymous and no one is able to identify that it's you, instead of using your name, we used a numerical format in terms of, and it's specific to your name, and we know that it's yours and it's specific to you. So no one else has it, and no one will be able to identify that specific participant as whoever will be. Thank you.
Any other question? We still have time. Questions, please. It looks like they are letting you off the hook, sir. Thank you very much for your presentation.
Thank you.
Okay, the next presentation will be Ritamfu. We don't have. Okay, we'll skip. No, it's fine. We were just locating your presentation, man. We'll call you. Okay. The next one will be Mahobatlo. Determination of spatial distribution of diabetes mellitus at the Dimamo Health and Demographic Surveillance Site, Limpopo Province, South Africa.
Okay, good afternoon, everyone. My name is Dineo Mahobatlo, and I'm from the Medical Science Unit in University of Limpopo. So today I'll be taking you through our research study titled Determination of Spatial Distribution of Diabetes mellitus at the Dikgale, Mamabulo, and Motapo Health and Demographic Surveillance Site, which is also known as Dimamo HDSS. So for introduction, spatial distribution is defined as the analysis of a certain phenomena that can be linked to the way diseases spread in a certain geographical location. So we've noticed that most studies on spatial distribution of diseases are mainly focusing on communicable diseases. So less attention has been paid to the spatial distribution or analysis of non-communicable diseases. So this might be because of the association between environmental risk factors with communicable diseases. So as a result, communicable diseases are then better managed. So there is less attention in studying spatial distribution of non-communicable diseases, especially among the Black populations. So this might be because it was previously thought that there is no association between environmental factors and non-communicable diseases. So the objectives of the study was to determine the spatial distribution of diabetes mellitus, and then also to correlate the spatial distribution of diabetes mellitus with environmental factors. The problem statement. So the burden of diabetes mellitus and diabetes-related mortality and disability are reported to be rising in Africa due to sedentary lifestyles as well as urbanization. So to develop appropriate and necessary interventions for diabetes mellitus, there is a need to use spatial analysis in determining the distribution of diabetes mellitus. Also, to determine if the distribution of diabetes mellitus is related to environmental factors. So the study therefore aimed to evaluate the spatial distribution of diabetes mellitus among rural Black populations in Limpopo Province, South Africa. So methodology, the study was retrospective, descriptive, cross-sectional, as well as quantitative. Sample size was 791, and then women were 549, men were 242. They were from 40 to 70 years of age, and then the study used data collected from 12 villages within the Dimamo HDSS. So because of the differences in the number of participants from each villages, so we then decided to group them into 4 clusters. So a data extraction tool was used to extract variables that were needed in this study. For example, your glucose levels, and also marital status, as well as the level of their education, just to mention a few. And then for data analysis, we used SPSS software for statistical analysis, and then we used the local Moran statistic software for spatial analysis. So inclusion criteria, this was basically a census sampling because we considered all participants that participated in the Awigen Phase 1 project. So those that were excluded we included those that did not have complete data that were required for the study. And then the results that we got, we found that the proportion or the prevalence of diabetes mellitus in this population was 6.4%, and then the proportion of diabetes mellitus was found to be highest in cluster 1, 7.1, although it was not significantly different when we compared with the other clusters. And then the proportion of diabetes mellitus was higher in women, 7.4, compared to men, 4.6%. This one was also not significantly different. So this is the map that we got when we used the local, after using the local Moran statistics software, we get this kind of mapping, and it also shows how the 12 villages were then grouped into 4 clusters. So the darker colors, the darker green color just shows that diabetes mellitus was seen in high quantity in those in cluster A, and then less means that that's where we got less prevalence of diabetes mellitus. And then we continued to look at the multivariate logistic regression. So here we looked at other variables like marital status, their level of education. We also checked high BMI, high cholesterol, high total cholesterol, and also if there was drinking alcohol consumption. So here, you'll pardon me, it's not hypertension, it's diabetes mellitus here. But then the values are correct. So we looked at the covariates, age, gender, and high blood pressure, as well as central obesity. So what we found was that gender was positively associated with diabetes mellitus, to be specific, women, and then also high blood pressure was also seen to have contributed to the distribution of diabetes mellitus, as well as central obesity. With marital status, level of education, we found that there was no association. Then in conclusion, there was no difference in the distribution of diabetes mellitus among the villages in Dimamo. And then the small sample size might have contributed to this. However, in the villages where there were differences, the differences were brought by higher proportion of women, higher proportion of people with central obesity, higher proportion of people with high blood pressure. So, I'm done. These were the references that I used, and then, thank you.
Thank you very much for your presentations. Let's questions. Questions?
Hello. Sorry. Hello. Thank you for your beautiful presentation. I just wanted to ask, with regards to the map that you showed us, what is the relation between where the person is coming from and them having diabetes mellitus?
I'm not sure if I get your question. The relationship between their exact location and the map.
You showed us a map there,
Yes.
which was showing a geographical distribution,
yes,
of patients with diabetes.
Yes.
There was that variation. Some areas they had more, or they had diabetes as compared to the other areas. So she's asking in terms of what could be the reasons for that.
Oh, okay. In the study, we found that the darker areas that you saw there, like there was, we found that there was an increase in waist circumference or central obesity. Like central obesity was contributing positively to the green parts. Central obesity as well as hypertension. So that's what we found.
Questions? There was a hand. There's no questions? We still have time.
Thank you very much. My dear, this is not a question. I'm not sure if I'm not from this province. So I just want to understand what is the MAMO HDS, because it seems to be a system that I'm not sure. Can you maybe tell me? I'm not sure what is the MAMO.
Okay, the MAMO HDS, it actually stands for Dikgale, Mama Bolo, and Motapo, Health and Demographic Surveillance Site. So it's a site, it includes these 3 villages, like they've got also sub-villages as well. So what happens is that it's sort of a center whereby they deal with cardiovascular or cardiometabolic research. So they recruit participants from those villages to come in, and then they do data collection on them, and then they send the results and then to vets. It's actually a big study. It's an Norwegian study. It's an Africa thingy. It's not just in Dimamo, but then Dimamo is one of it falls under, it's one of the centers where this study is conducted. I'm not sure if I've answered you.
Any other question? Going once, twice, all right. Thank you very much, ma'am, for your presentation.
Thank you.
All right, our next presenter is going to be Maleka EM, who will be presenting effects of obesity change on 10-year cardiovascular risk, Dimamo Health and Demographic Surveillance Site, Limpopo Province, South Africa.
Afternoon, everyone. I'm Maleka Mulebore. Together with my group, I'll be presenting a study about the determination of effect of change in obesity in Framingham risk score among adults aged between 40 and above residing in Dimamo HDSS, Limpopo Province, South Africa. The introduction on cardiovascular diseases, it refers to diseases that affect the heart and the blood vessels, which are becoming a burden worldwide, accounting for 18% of all deaths in South Africa. And these cardiovascular diseases can be estimated or diagnosed with various methods, one of the methods being Framingham risk score, which is going to predict the 10-year risk factor risk of developing cardiovascular diseases. The Framingham risk score can also be affected by obesity. Obesity being defined as one having the body mass index of plus or equal greater than 30 kg per meter squared, which results from the imbalance between energy intake and expenditure. In 2022, 2.5 billion adults were reported to being overweight globally, with 43% being men and 44% being female women. And in 2016, it was revealed that 68% of women and 31% of men were either overweight or obese, highlighting the growing burden of obesity and its impact on public health. Moving on to the problem statement, literature demonstrated that there's association between obesity and elevated risk factor that contribute to increased cardiovascular diseases. However, there's few studies that in rural areas that talk about how the change in obesity affect the Framingham risk score. And most of the present studies, the ones that are available, they are cross-sectional. Therefore, the aim of this study was to determine the change in obesity status on Framingham risk score in adults aged 40 years and older in the MAMO HDSS over a period of 5 years. Moving on, the research objective. The research objective was to determine the change in obesity prevalence over a 5-year period. Then the other one was to compare the Framingham risk score baseline and from baseline and the 5-year follow-up. And the last one was to determine the correlation between the change in obesity status and the Framingham risk score, leading us to the research question being, what is the effect of the change in obesity on the Framingham risk score among adults aged 40 and above residing in the MAMO HDSS over a 5-year period? Moving into our research methodology, this research was retrospective longitudinal as it used data from Awijan phase 1 and phase 2. The research area was the Capricorn District Municipality of Limpopo Province, with all participants in the Awijan phase 1 and phase 2 project database aged 40 and above used as our research population. Then we used census sampling method to sample our participants with inclusions of criteria of all the participants who participated in phase 1 and phase 2. Then also the exclusion of all the participants with missing data needed for Framingham risk score and for obesity, leading us to the sample size of 85 adults, 73 females, and 12 males. Moving into how the data was collected. The data for Framingham risk score variables and obesity were collected using the data extraction tool. And the diagnosis of obesity was based on the body mass index of greater or equals to 30 kilograms per meter squared. With the Framingham risk score diagnosis, males with less than 10 points at low risk, 11 to 14 points at intermediate risk, and greater than or equals to 15 points as high risk. And for females with points less than 12 as low risk, 13 to 17 points as intermediate risk, and greater or equals to 18 as high risk. Data was analyzed using SPSS version 29.0 software, where we used one-way ANOVA to compare the variables among Framingham risk levels, and the chi-square was used to correlate the proportion of risk variables for Framingham risk score and diabetes. And the p-value of less or equals to 0.05 was used as the threshold for significance for all the statistical tests. With ethical approval to conduct the study granted by TEFLOP Research Ethics Committee, and the permission to use the data by Awigen, and the non-consent form were used as we were using secondary data. Then we used research identifiers to maintain anonymity and to ensure confidentiality. Confidentiality agreements forms were signed, and maleficence did not apply in the study as the study used secondary data. Moving to the results, 58.5% of overall prevalence of obesity was seen being more prevalent in females with 65.5% than males with 16.79%. Then moving on to the graphs, the first graph of phase 1 was the normal, was the patient who were normal, then they became obese in phase 2, focusing on the change in the prevalence of high Framingham risk score between them, which gave us the same high prevalence of elevated Framingham risk score at 75%. Moving on to figure 1.2, there was, on figure 1.2, phase 1 is the ones who were obese, and phase 2 is on phase 2 they became normal, which shows the difference in the prevalence of high Framingham risk score in the group of participants, which showed that the prevalence was high in phase 1 with 44.4% compared to phase 2 with 33.3%.
to a deficiency of insulin. And then in type 2, which is the most prevalent, we see insulin resistance, which is usually caused by lifestyle factors such as lack of exercise. Insulin, to elaborate further, and I need the audience to take this into cognizance, is a hormone that plays a very, very crucial role in the management or facilitation of glucose in the blood. According to the World Health Organization, approximately 530 million people worldwide are afflicted with this disorder. And according to a 2024 study, more than 4 million people in South Africa are living with this condition. It is also one of the leading causes of death. Vitamin B12, which is also called cobalamin, and folate are water-soluble micronutrients that play a very, very vital role in the formation of nucleic acids within hematopoietic cells. The lack of these nutrients usually leads to hematological disorders such as megaloblastic anemia, wherein it's a form of anemia where we see the cells are larger than the reference range. Studies have suggested that there is a correlation between cobalamin, which is vitamin B12, and folate with glucose levels. Studies have also linked changes in hematological parameters, which are parameters associated with blood and blood-forming organs with uncontrolled diabetes mellitus. Our problem statement is as follows. The deficiency of vitamin B12 and folate was described in polyuria-associated conditions linked to diabetes mellitus. Although vitamin B12, folate, and hematological parameters such as red blood cell count are known to be affected in diabetes mellitus, a proper association with glucose in these parameters has not been adequately studied or established, especially in rural areas in Limpopo. So to address this lack of information, we conducted the study. The aim of the study is to determine the association of vitamin B12, folate, and hematological parameters with glucose in the semi-rural area of Hamutabo in the Limpopo province, South Africa. Moving on to our objectives, we have 3 objectives. The first one is to extract participants' data on vitamin B12, folate, and hematological parameters. The second one is to compare diabetic participants with non-diabetic participants. And then the third and final objective is to glucose with vitamin B12, folate, and Our methodology is as follows. Our study, in terms of its design, was cross-sectional, retrospective, descriptive, and quantitative. We extracted data from 379 participants between the ages of 18 and 65. The study relied on secondary data. However, in the primary study, convenience sampling was utilized. Data was analyzed using the SPSS version 30, and then ethical approval was sought from the relevant parties. Our results are as follows. We had 379 participants, 95 being male and 284 being females, with 52 of these participants being diabetic. The mean age was 44. BMI had a correlation with glucose levels. It is also important to note that hyperadiposity, which is obesity, is seen as a risk factor for diabetes mellitus. And it was also seen that the higher the glucose levels, the greater the BMI. Diabetic and non-diabetic participants had a normal platelet and leukocyte count. This chart or these tables show the gender distribution of participants and also the proportion of participants with or without diabetes mellitus. So our participants, 25% of them were male, 75% of them were female, and then our diabetic participants, only 14%, we had only 14 participants that were diabetic, and then 86% of the participants were non-diabetic. The following chart depicts the prevalences of hematological parameters, folate and vitamin B12 in diabetics and non-diabetics. So I need you to look at the chart, and the first variable that we looked at was low vitamin B12, and it was seen that in diabetics, they had a higher percentage of lower vitamin B12, And then in the folate as well was also significantly low in the diabetic participants. It is also important to take into cognizance that our platelet count in diabetics was higher than the non-diabetics. Our white blood cell count, which is leukocyte count, was a little bit higher in diabetic patients, and that is due to the hyperinflammatory state of diabetes. The chronic presence of glucose within the blood might lead to immunological reaction. So this explains the higher YBC count. And then also our RBC count was the same, wasn't too different. And then the MCHC, which is the mean corpuscular volume, was the same as well. There wasn't really much change. The same applies with MCV. There wasn't really much of a strong correlation. Folate was seen to have a negative correlation with glucose. Vitamin B12 was also negatively correlated with glucose. What this means is folate and vitamin B12 were lower. The greater the hyperglycemia, which is diabetes, the lower the folate and vitamin B12. And that is because diabetes mellitus is a polyuria-associated condition, and these micronutrients are water-soluble, so they might have been excreted during the polyuria itself. The leukocyte count, although it was normal as aforementioned, it correlated significantly with glucose levels for the reasons that I mentioned. Our conclusion is as follows. The glucose levels are negatively and significantly associated with vitamin B12 and folate. And of the hematological parameters assessed, it was found that there was no association with glucose except for leukocytes that were seen to be higher in diabetic participants. Our limitations, we only had two limitations. The first one was a small sample size in comparison to the prevalence of the disease. As I mentioned earlier on, there are 4 million people with the condition in South Africa, and we could only find 52 participants. So that we had a very, very small sample size of diabetic participants. And we also focused on a very, very small area as well, that is in the Hamutabo area. So it is therefore recommended to conduct a study with a bigger sample size and a larger study area. Our references, those are our 4 references, and I'll conclude my presentation here. I'd like to thank my department, and I'd like to thank my supervisor, Ms. Kataka, and my Mr. Choma, who is my program coordinator, for assisting me with this presentation. Thank you.
Thank you very much for your presentation. Let's take questions.
Thank you so much for a very concise presentation. I think we acknowledge that the sample size was quite small, as you have made a disclaimer on that. But I just want to ask a question in terms of the correlation between BMI and diabetes mellitus. Was it across all participants or the majority of those that participated? Thank you.
Thank you for the question, Sam. All of the participants were, the BMI correlated significantly with glucose when it comes to all the participants. It was the same throughout. The higher the BMI, the greater the glucose levels. So that was uniform, sir. Thank you.
Thank you for the nice study. Now, in the near future, since you're saying you advise that they should look at a bigger sample to repeat the study, what will be your hypothesis in terms of the vitamin B12 and folate? Will your hypothesis be saying that vitamin B12 and folate deficiency causes diabetes or not?
Oh, thank you for the question, sir. No, it's the other way around, actually. Diabetes is the one that causes the decreased state of vitamin B12 and folate. So that's going to be my hypothesis.
Another question?
Thank you so much. That was a very nice study. I think it's a very nice and relevant study. I think as a hypothesis for what you would study further, you would actually then look to see why patients with diabetes tend to have low folate and vitamin B12. I think you try to explain it, but it deserves study. It's fair to actually study it because it's important. You can imagine already you've got diabetes and now you've got low vitamin B12, low folate. You will have symptoms. You will actually get sicker. So I think it's very nice. I think it's very relevant in that regard. You can actually follow that up.
Okay, thank you so much for your lovely presentation. I just have
I am going to be the person who makes sure that things are running smoothly when it comes to presentations during this time. I just want to remind my colleagues, my esteemed colleagues, that we are here gathered at this conference to search for ways to advance universal health coverage. But this session in particular, it's looking at health promotion advocacy and health systems strengthening. So, before I proceed, I just want to find out if the presenters are here. The presenters in this session, we have Neuhoff. Thank you, you are here. He is going to be presenting knowledge, attitude and practices of Bloemfontein residents on disposal of unused medicines. The second presenter is going to be Maribeng ER. Thank you. She's going to be presenting exploring the management modalities for a pediatric population, presenting with binocular vision anomalies in public health care facilities in Limpopo province. Our third presenter is Maifo NL. Okay, thank you so much. He is going to be presenting evaluation of Skip the Cure intervention implemented to reduce patient waiting times at an outpatient pharmacy of a tertiary hospital in Gauteng province. The fourth presenter is Nemahunguni TD. Nemahunguni, are you here? Okay. Looks like we don't have the third presenter, and the final presenter, it's going to be Ngwenya, MW. Okay, Ngwenya, you are here. Ngwenya will be presenting midwives' practice challenges in triaging expectant mothers, a qualitative study in Mpumalanga maternity unit, South Africa. Let me see if our judges are here. Timekeeper judges. Judge? Okay. Another judge? Thank you. And timekeeper? Can we have, oh, thank you so much. Okay, so without wasting time, let me just give you some few instructions. I was told, or I learned from other sessions, that the presentations are 15 minutes. I hope 10 minutes is presentation and 5 minutes is Q&A. Without wasting time, I hope our first presenter is ready. Let me remind you the name and the topic of our first presenter. Neuhoff, JFR, and Gutsie, representing Gutsie BC, and Vagiri RV. They're going to be telling us about the knowledge, attitude, and practices of Bloemfontein residents on disposal of unused medicines. A hand of applause for them.
Thank you so much. Thank you, Prof. Chichangano, and thank you for the warm welcome. I think as it's been described, let me just see if we can find the files here. Hello, sir. That's a good question. The presentation, is it? Yeah, that's a good question. It wasn't supposed to be on the USB. Okay, so we're just going to wait just for the presentation to appear on the screens, and then I'll begin. Fantastic. There we go. Okay. So as it's been brought up before, I'll be discussing. My name is Rudy Nyof, and I'll be discussing the knowledge, attitudes, and practices of Bloemfontein residents on the disposal of unused medicine. So, as populations rise, so does medicine consumption. But what about the unused medicines? So, improper disposal of medicines is becoming a burgeoning global and local issue. I think we've seen every now and then a headline pops up in the news that, for example, we found HIV antiretrovirals in water sources in the Northwest Province. And that's actually not a new issue. That research has been going on since 2015. So I can only imagine this problem getting worse. So just as an introduction, there's been no studies on this matter done in Bloemfontein, and only 4 other studies have been done in South Africa. To add to that, no study has actually looked at the attitudes of any of the residents. So naturally, the study's aim is to assess the knowledge, attitudes, and practices of residents of Bloemfontein on the disposal of unused medicines. That being said, the study's objective sets out to measure residents' knowledge, attitudes, and practices, then identify socio-demographic differences of their knowledge, attitudes, and practices, and then find predictors of their knowledge, attitudes, and practices. So the significance of the sub-study, well, yes, as I've brought up before, it will be the first in Bloemfontein, also the first study in South Africa that incorporates attitudes into its methodology. The study will also support public and health and policy, and I believe it highlights the role of pharmacists who, as has been described, are custodians of medicines. And I think that really means from cradle to grave. And I think we're ignoring that a little bit. But also other healthcare professionals. So moving on to the methods of the study, the design is a quantitative, descriptive, cross-sectional study which used a questionnaire as its instrument, which was just translated into 3 different languages to accommodate the residents of Bloemfontein, and consisted of 16 questions. There were 9 socio-demographic questions to highlight and incorporate a large amount of socio-demographic data and variables. There were 4 knowledge questions in which a scalar scoring method was used. There were 4 attitude questions in which a Likert scale was used, and 4 practice questions in which a scalar scoring was again used. The sample consisted of 394 residents in Bloemfontein, all aged above 18. And with regards to analysis, statistical analysis was performed in SPSS. That included a Spearman correlation test, a multiple regression test, a Kruskal-Wallis test, and also a Komarov-Smirnov test. So moving on to the demographics, the mean age of the population was found to be 38.2 years. Majority of the population was female at 60.9%. They were employed. They had a tertiary education and an income of under 20,000 rand. And it was also found that 9.4% of the population, or the sample tested, were healthcare workers. That resulted in 37 participants. Moving on to the knowledge results. The total average score of the knowledge results resulted in 46.7%, where it was found, high knowledge was found in females, the employed, private healthcare users, and healthcare workers. Just by the way, that will be a trend throughout the study, that healthcare workers did score more in all 3 sections. Moving on to the knowledge gaps. Gaps are found in public healthcare users, the unemployed, and students. With regards to the predictors of the study, with respect to the knowledge results, being a healthcare worker was found to be a predictor. females were found to be a predictor. Again, females were found to be predictors in both knowledge and practices. Being unemployed was also found to be a predictor of more knowledge or a higher knowledge of medicine disposal or appropriate medicine disposal. With regards to their attitudes were quite overwhelmingly positive at 82.5%. Higher attitudes were found in those with a higher education and again in healthcare workers. So with regards to these results, it's found generally that people have the desire to dispose, however, they lack the information, especially in the public sector. Predictors, again, was being a healthcare worker for a higher attitude with regards to the appropriate disposal of medication. Moving on to the practice results, total average score of only 8.5% was achieved. That's very poor, dismal in fact. Healthcare workers didn't score much higher at an average of 0.68. This unfortunately leads to, or it was found that the most common unsafe disposal methods was through household waste and through the sewage. Again, the predictors, I've mentioned before, females having a higher educational status and being a healthcare worker. With regards to the Spearman test that was performed to find out the correlation between any of the three arenas, knowledge, attitudes, and practices, there was a weak positive relationship found between attitudes and knowledge of appropriate medicine disposal. Moving on to discussion, practices and knowledge scores were found to be similar to that of the other 4 studies performed in South Africa. Although healthcare workers did score higher, especially with regards to the knowledge and, unfortunately, not the practice sections, they did score higher than the general population. And users of a common thread emerged where users of the healthcare system, they said they lacked information available, lacked of available information in order to make informed decisions about discarding of medicine appropriately. And unfortunately, they had a lower total knowledge score. And also, interestingly enough, they also had the lowest practices score. So there's definitely a gap there. With regards to the conclusions, significant gaps are found in knowledge, attitudes, and practices, which supported other studies. Healthcare workers, like I've said, possessed a greater knowledge, attitudes, and practices regarding the subject. Again, as I've alluded to before, this suggests there's a willingness to dispose of medicine properly. Unfortunately, we believe there's not enough disposal opportunities and awareness. Again, just to highlight that, females were found to dispose of medicine. Females were found to be a predictor, a socio-demographic predictor as to disposing of a medicine appropriately, as well as those who had gainful employment and had a greater income and had a higher educational status. Again, this leads to our recommendations. 2 recommendations that I could highlight here was just increase awareness and increase the disposal opportunities. We also recommend starting with policy reinforcement and community engagement. That marks the end of my presentation. I'd really just like to say thank you for your time, and thank you to my facilitator, Dr. Vagiri, and Prof. Ndlotu, who also helped a lot throughout the 3 shifts. Thank you.
I have realized, research is a good thing. I have realized that being a female and having higher education, and again are predictors of risky disposal of medication. I'm not sure if you heard me. So when you look at me, am I a predictor? Any question? Any questions? Oh, okay.
Afternoon, Mr. Nuhoff. Thank you very much for the presentation. though I'm having a question, I don't know whether it's a question or a comment, but I want some clarity from you. You indicated that there were some previous studies that were conducted under your topic, and then you continued with that. So I just want to know, after you've studies about the knowledge, the attitude about the problem, did you have any strategies that you didn't think of? Maybe how can you apply the strategies? Because according to your recommendation, you have just indicated about strengthening the opportunities and the awareness. So how about maybe you develop some strategies, because there were some previous studies that were done, they've done the same, so you have also done the same. So you didn't think of about any maybe application of some of the strategies. Thank you very much.
Yeah, sure. Thank you for the question. Definitely, I think maybe for a start, if you read just the package insert, which is a legal requirement in medicines, it doesn't have, most of the time, it doesn't have any guidance as to how to dispose of the medicine. And that currently it's not a legal requirement. So even just starting there, I mean, right there with companies that produce the product. Also, I think also it should be up to pharmacies to maybe also let people know they can bring in their medication for safe disposal.
You are noted, a lady over there, and there is another hand that I saw here and another one there.
Good afternoon, sir. Thank you so much for the nice presentation. My question is very simple, more like a follow-up to the previous one. You've got 4 studies conducted. Based on that information and your choice of the research site, why Bloemfontein?
Yes.
And just on a follow-up also to say, why Bloemfontein? Remember, Bloemfontein is urban. How do you make sure that this information is cascaded down to rural areas? Thank you.
With regards to information being cascaded down to, thank you for the question, firstly. Firstly, Bloemfontein was chosen because it was central as well in South Africa. So that was one of the reasons it was chosen. It is a capital city. It's another reason it was chosen. It is, it's also, yes, like you said, it is quite urban. But with regards to, say, cascading that information down to more rural areas, I think that could be perhaps done through clinics or through a public health service. Sorry, have I answered your question? Sorry.
It's just maybe a feature.
Oh, okay. Oh, thank you. Okay,
there's another hand there and over there.
Yeah, your study is very interesting. I just want to find out, does educational level affect how people practice disposal of medication? It seems like, based on your study, those that are coming from high income or educated are predisposed, what?
Or predictors, yes, those populations are predictors.
So if
yes.
they're coming from rural areas, how does that affect the disposal of medication? And also, based on your recommendation, you said there should be proper disposal opportunity. Who's supposed to create those proper disposal opportunities?
Okay. Thank you for your question. So I believe there's really 3 parts to your question. So the first part then revolved around the sorry.
Level of education.
Yes, that's right. Sorry, the level of education. Yes, so I think I did highlight that, but yes, it is a predictor, to put it bluntly, as to somebody disposing of education more appropriately. Yes.
And what about those that are in rural areas?
Yes, so then your second part of that question as to the those in rural areas. because the study was done, in an urban area, those factors weren't necessarily considered, so I can't give you an appropriate answer, at this time. Sorry. With regards to the third part that you brought up, well, essentially, if you're getting medicine at a pharmacy, which you should be, or in, say, a sister's room's a medicine room, those facilities should have adequate and appropriate medicine waste sites or opportunities to dispose of those medicines. So that really in itself should create opportunities. If those staff and those employees, those pharmacists or nurses are adequately trained. Sorry, have I answered your question?
Thank you very much with such a wonderful presentation. I just need clarity on this one. Did you develop this questionnaire or you adjusted the questionnaire? If you have developed the questionnaire, how did you validate it?
Well, thank you for the question. No, I did not develop the questionnaire. It was adapted from previous studies that then also validated it. I also performed a trial of the questionnaire before actually implementing it.
All right. You said, okay, just to make it...
His time is up. These other things...
Sure.
Thank you. Let us give him a hand of applause. Yes, I am also going to ask him where the 4 previous studies were conducted so that we see, or we determine whether there was a need for this study in Bloemfontein, and also what the impact is of risky disposal of medication, because we, like it has been indicated, high education, being a female, we are predictors of risky disposal. So maybe it's important that we know or we find out about that. So our second presenter is going to be, I am playing a dam because we have one presenter who is not available, and so we have his or her 15 minutes. Is he there? Okay. Our second presenter is Maribeng ER. He is coming, or he or she is coming to present exploring the management modalities for a pediatric population presenting with binocular vision anomalies in public health care facilities of Limpopo Province, South Africa. A hand of applause for her. This one. Get today. 17:09 or 20. Get today in the morning. Is it gonna run there? Okay. I sent her the email.
Oh, you have one. Sorry.
Oh, no, laptop.
No, can only use the page. Can I learn unless okay.
Just check if you don't have it first.
It doesn't show. I won't check it.
Yeah, can I?
Okay.
So I just tap when I move on. Good afternoon, Chair, the judges and my audience is large. My name is Maribeng ER. I'll be presenting my research titled Exploring the Management Modalities for Pediatric Population, presenting with binocular vision anomalies in public healthcare facilities in Limpopo Province, South Africa. And I'm not so sure my slides are not projected on the screen, but otherwise on the background, binocular vision is vision with two eyes. The integration of two images received by two eyes into one single percept. So any misalignment of the eyes will result with binocular vision anomalies. Pediatric population is increasingly overburdened by many healthcare. Okay. Okay, pediatric population is increasingly overburdened by many eye health conditions that affect the quality of life worldwide. Binocular vision examples like strabismus, amblyopia, convergence dysfunctions, and accommodative dysfunctions. These anomalies were researched worldwide. Hassan Dean assessed the prevalence of these conditions and reported convergence insufficiency to be more prevalent in India with 16.5% and 17.6% in rural areas. Franco also did the prevalence assessment and then reported divergence disorders as 30% and accommodative disorders is 9.4% in Spain. Obokuba in Ghana did the assessment of the management of binocular vision conditions and also reported that 70.6% is seen by optometrists of accommodative dysfunction and vergence dysfunction, 56.9%. And Obokuba also reported on the type of management modalities used to assess this condition or to manage this condition, and reported that optometrists in Ghana used added lenses and vision therapy to manage this condition. Missing also did the prevalence of these conditions in South Africa, Johannesburg, and reported vergence in facility to be 21.9, followed by accommodative dysfunction and convergence dysfunction. No one assessed the management modalities of the binocular vision management in South Africa. And my problem statement, of course, maintaining good binocular vision status plays an essential role in the lives of pediatrics. So noting that there's an array or numerous transfer or referral of patients from the hospitals to the university, and also intertransfer or referral of patients from districts hospital to tertiary hospitals, made me see that as a problem.
thinking about the question. Let her summarize just the management modalities.
Yes.
Please.
Yes. Thank you for that. We discovered, or we find that a majority of the optometrists use spectacles other than any other management modalities. For example, they preferred to use spectacles to manage strabismus, whereas Portela recommended prisms to manage for convergence insufficiency and strabismus. And none of them used drugs to manage amblyopia, yet amblyopia was the second reported conditions, but they use spectacles also to do that. So yeah, in conclusion, half of the participants reported to be managing, and strabismus on amblyopia was the most prevalent conditions, and then lack of equipment was the hindrance for none of management for these conditions. Thank you. And then we recommended that there should be training and, yeah.
Thank you so much. Any question? The reason why I wanted her to emphasize on the management modalities is that if you had listened to her properly, she's indicating that there are people who are making use of spectacles when they are not needed. Is that not important information for you, audience? It is. Okay, questions now. Okay, thank you so much. Your time is up. They don't have questions.
Thank you.
A hand of applause for her for the last slide. Okay, we have Moafi, our third presenter, who's going to be represented by Dr. Vagiri. I hope they are ready with the presentation. Let me tell you what the presentation is all about. I know you have the okay, they are evaluating skip the queue intervention implemented to reduce patient waiting times at an outpatient pharmacy of a tertiary hospital in Gauteng. They will tell us what skip the queue intervention implementation found. Over to you, Dr. Vagiri, on behalf of Maifo and Prof. Nolutu.
Okay. Good afternoon, colleagues. Yeah, as you can see, as it was explained to you, I'm representing my student who had to go for an operation yesterday and she couldn't make it. So I had to step in and then present her research. Just to give you an introduction, if you go to a public sector institution and you are about to see a doctor, then nursing services, maybe visit 2 or 3 clinics, and then end up at pharmacy, at what time do you go to the hospital? If you were to go to maybe George Mukari, Steve Biko, general question, maybe 3 o'clock, 4 o'clock, 5 o'clock, right? And you are lucky if you can finish by 4 o'clock. 4 o'clock you came out, got home at 6 o'clock is really a miracle, right? So this is really happening at some of the institutions. Our study site is no different to this particular challenge. Long waiting times, as you all know, this is, sometimes you may think that is over-researched topic, but all the presentations are different to my presentation because I'm coming up with a solution. I'm not recommending, I'm recommending a solution, okay? That's what I'm trying to do. So long waiting times, they have a negative effect on patients. You know it, patients are frustrated. They lose income because today they have to go for a day job or a piece job. Now they have to go to the hospital, collect the medication, they lose that income. And then medication adherence. Some of them, they wait for 2 hours, they don't know when are they going to get the medication. They end up not collecting the medication. So obviously they won't be adherent. And then the risk of drug resistance, especially with the tuberculosis medicines, antiretrovirals, it can happen that the patients may skip the medication or not collect the medication, which can result in resistance and deterioration of the health. Some people will say, I don't want to go to this hospital just because I know I'm going to wait for the whole day. I would rather go and buy something for 10 rand, I'm fine for the month. This is the challenge that we have. So in South Africa, you know, you have worked extensively on waiting times. You had a lot of things about waiting times. But the problem is that we had lots of interventions in place, but nothing seems to be working. I would discuss some few interventions that were implemented recently. CCMDD is one thing. PDU, CDU, community, PDU, pharmacist dispensing unit, community dispensing units. Every institution, they would have their own way, the fast queue, this queue, that queue, but still, the patients are not happy. You can Google any hospital nearest to you, check what is their Google rating. If they can get 4 or 5, that's a miracle. Everybody would say that I waited long to get my file. I waited very long to see the doctor. I waited very long at the pharmacy. But all the patients, end of the day, they would end up at the pharmacy, and that's where their satisfaction really lies. And then, recently in 2024, at the tertiary site, tertiary hospital, Kalafong Hospital, they've implemented a new program called Skip the Queue program. And the purpose of that was to reduce the long waiting times at Kalafong Hospital. And then, this is the solution that I'm recommending, because this is an online program that Kalafong Hospital and Gauteng Department of Health have actually accepted it, and they are actually creating good results with this. What is this program all about? So this is a promise that was given by Kalafong Hospital and Gauteng Department of Health, that whoever has used this online Skip the Queue program, they would not wait more than 15 minutes to collect their medication. 15 minutes is what they have promised. So what happens here is that the patients would have to go to an online website or WhatsApp. They register through Skip the program, and then they will book a particular slot to say that I'm going to collect this medication on 18th of September at 2 o'clock. That's what they will do. And then if the slot is available, then obviously your medication will be ready. And when you go to the pharmacy, 15 minutes down the line, the medication is ready for collection. Okay? So it seems easy, right? But the program, the Skip the Queue program, the online program, is something the hospital is actually implementing in the current format. So generally, if you have collected your medication and you want to collect your medication for next month, book an appointment. Go to the website, choose the date, choose the time, and then at least before 7 days you have to book so that they can prepare your file, they have to retrieve your file, get the medication, prepare everything, and then all those things. But once you have missed a slot, then it becomes a problem. Then you'll have to come to the pharmacy again and collect your medication. That's the downside of it, but they're working on it. So obviously, yes, this is a nice program that was implemented everywhere. I mean, at Kalafong Hospital. But as a researcher, we want to see if it's really working. Yes, you're promising a new product. Is it really working or not? So that was our main aim. And then we wanted to see what was the average waiting time previously, and what was the average waiting time with Skip the Queue program. And then we also wanted to evaluate what is the satisfaction of the patients relating to this program. Are they happy? Because you are showcasing in the news and in the media everywhere that this is a nice program, it's working very well, patients are very happy. But we wanted to know, are the patients really happy with this program? And we also want to identify the challenges associated with this program, the access, website, there is always a problem, and also with the collection, what are those things? So with the methodology here, obviously it's a descriptive, quantitative, and cross-sectional study that we did. Study population included 297 participants, and then all the protocols were observed in terms of inclusion and exclusion criteria, and then they have all provided written consent to participate. We have also done a power analysis to identify if this 297 is sufficient for this study or not. Although the sample size calculation was done, we also did power analysis to identify if it was sufficient. And then we got ethical considerations. All the ethical protocols were applied. We received approvals from TREC and the Department of Health and also the hospital. And the data collection was conducted for a period of 5 to 6 weeks, I remember. And then there was a questionnaire for satisfaction, measurement, and the socio-demographic data, all those things were done. And then we did the statistics. The main three tests that we did was use of Mann-Whitney U-test and Kruskal-Wallis H-test, because our data is not parametric. So some of the times you will say that I want to use one-way ANOVA. If the data is not parametric, you cannot use one-way ANOVA. So obviously we have to use Mann-Whitney and Kruskal-Wallis. And then the outcomes, obviously we want to see the associations, all those things. The questionnaires, all the tools were available in English, Afrikaans, and Setswana. And then information sheet was given to the patients. All those things were done. The tool consisted of 12 questions ranging on a Likert scale ranging from 0 to 48. So 0 to 4 is the maximum score. And then whatever that the score of 36, over 36, we considered that the patients are happy with this, with the program. So these are some of the socio-demographic characteristics. And then one important thing that I want to show is that almost 94% they have time to access. Yes. Okay, it's fine. So then how did we achieve this? Okay, although more than 3/4 of the patients have expressed satisfaction with this program, and some of the things that they expressed very good satisfaction is with the packaging and labeling of medicines. They were ready for them. The staff were very professionalized, and then ease of access to the collection points, and they would recommend this program to the others. Patients who reported, who had data affordability, they reported good satisfaction, and then employment, especially the pensioner reported good satisfaction because they had time, and then if they had successful booking, they reported good satisfaction. Preferred slot, also good satisfaction. Impact on the average waiting time, this is one of the objective. After they skip the queue intervention, the average waiting time was 29 minutes. Previously, it was 87 minutes. Although the promise is 15 minutes, the waiting times were reduced from 87 minutes to 29 minutes. So what am I saying here? I'm saying that please give it a try with this program. Implement at your institution if it's possible, if you have the resources, because we have proved that the patients are happy with this program, and it can also work at your institution. Thank you.
Thank you so much. Any question?
Thank you so much for a good presentation. Mine is one. What does this keep the Q program bring? What difference does this skip the Q program brings to the healthcare workers? Because from what I've heard, it favors more patients, and nothing was said on when it comes to the healthcare workers in terms of the workload.
A patient is a patient. If you are seeing 300 patients, obviously you have to work with those 300 patients. But what I've noticed is that there are time slots where the staff members are not busy. For example, morning 7:30 to 10, okay? They're free. So they could actually prepare these parcels well in advance for the patients to come, okay? That would have had an effect on the staff morale because they're not working very hard throughout the day. Some of the workload is equally distributed throughout the day. But generally, in healthcare sector, our main focus is on the patient. So if the patient is happy, obviously, it's good that way. But healthcare workers, wherever they are, they will suffer, generally.
Any other question?
Sorry. Thank you for the presentation. I'm a professional nurse and I work at a clinic. We have what we call a CCMDD program. I just wanted to find out what's the difference between the Skip the Queue program and the CCMDD program that we're already using.
That's a good question. If you would notice, most of our patients, they love us so much, right? They want to come to our hospital. They want to come to the clinic. They want to see that favorite nurse. They want to see the doctor. Otherwise, they're not happy. Although there were measures that were put in place to down-refer them to the nearest clinic or to the closest center, okay? But let's say on CCMDD, you have given them a prescription for 3 months or 6 months, there is a high possibility that this patient would still come back to the clinic saying that I did not receive this, I did not receive this, I'm not happy, I think my viral load is high, something is high, okay? My blood pressure is high. That's where the problem it is. So we're not actually taking the patient out of the institution. Yes, it's fine, but come at your own time. If I gave you 2 o'clock, come at 2 o'clock. Because there are some patients who would be happy to come to the clinic, still see a nurse, check their blood pressure and blood glucose, go to the pharmacy at 2 o'clock, collect their parcel at that specified time. CCMDD is a good program, but the problem is the retention is a problem. You would recruit 100 patients, after 1 year, you will only find 50. Thank you.
Thank you so much. His time is up. Yeah, there's a hand, but we may take, thank you. Yes, thank you so much. A hand of applause for him. And don't worry about healthcare workers. NHI is on its way. So our next presenter was supposed to be Nema Ngowi. Or Nema Hunguni. Is Nema Hunguni here with us? If not, let's quickly call upon Ngwenya MW, who's representing Prof. Motero, Rasweswe, and Prof. Motiba. They are telling us about midwives' practice challenges in triaging expectant mothers, a qualitative study. Over to you.
Thank you. I can't see my slides.
He's coming.
Oh. Good afternoon, ladies and gentlemen, doctors, professors. I hope you are having a wonderful day. Standing before you, as already introduced, is Ngwenya Mxolisi from the Department of Nursing. So I'll be presenting a study entitled Midwives' Practice Challenges in Triaging Expectant Mothers. So this study is part of a large project. I think last year I presented the triage practices. Today we are looking at the challenges that they face when they triage. So my question to you is, did you know that with the maternal mortalities, every woman dies in each and every 2 minutes worldwide? To show that maternal mortality is a concern, and 97 of those mortalities, they occur in sub-Saharan countries, and they are preventable. One of the causes is delay in receiving care upon arrival in maternity units. However, to curb this, we have implemented triage systems in public hospitals and private hospitals, whether digital or paper-based. But with these interventions that are implemented, there are still challenges. With the triage system in maternity unit is not properly understood. It's still a relatively new concept when it comes to maternity units. Yes, we do have it in casualties emergency unit, but we don't have it in maternity units. So now, on the previous study, we have identified that midwives adopt several triage practices in Mpumalanga province. One of them being triaging by inspection, by mere looking of the patient, and you tell, oh, this patient needs an emergency care. The other one being that you look at the patient's clinical history, and then from there, you devise a plan on how you should care for the patient. The other one being observation, still goes with the inspection. So now, we wanted to know what challenges do the midwives have when they're triaging the patients based on those triage practices that they implemented. So this study, we explored those practice challenges when triaging expectant mothers with a qualitative, exploratory, descriptive design where we interviewed about 20 midwives in Mpumalanga province, in district hospitals of Mpumalanga. That saturation was reached with the 20th participant. So out of all the midwives that were interviewed, 19 were females. So from their results, we found that there are institutional related practice challenges, the challenges that impeded the midwives from proper triaging the patients. One of them was absence of management support. The midwives indicated that they receive more blame from their management than a pat in the shoulder for a good work, which indicates that there's a problem now when it comes to delivering quality care for maternal health services. Does this mean we are moving forward or backward? Right. So on top of that, they indicated that they're in short of equipment and supply to implement the quality triage system or the triage practices that they have in place. They indicated that they lack protocols and policies which they can implement and guide them on how they should triage pregnant women effectively. Some of the challenges were human resource shortage, poor infrastructure, and communication barrier. They overemphasized that with South Africa at the current moment, we have migration issues. So now you find out they can't communicate properly with some of the patients since they lack translators within the hospitals to communicate with the women on how they can triage based on the history that is provided by the patient. So that proves to be difficult for them. Another communication barrier was the malfunctioning switchboards so that they can communicate with the doctor when they need one. So there were also patient-related practice, language barrier already explained, lack of honesty. They indicated that with patients, they are hardly honest on how, for example, a patient coming to labor ward and not telling you how many babies they have. So some of the information, they hold it back in such a way that they can't triage effectively because, for example, they indicated in terms of gravidity, the number of babies you have has an impact on how long the labor will last. So those were the things that they needed to be attended to. Misunderstanding of triage. They indicated that some patients don't understand what triage is. Why is it done? Should I take the first person before you? Patients, they start to complain. So this indicates that there's a need to teach our society on how to triage. There's a need to look at their perspective on why triage is done. There is a knowledge gap amongst our society. So there were midwives-related practice challenges. Some of them were ineptitude and poor teamwork. So it seems some of the midwives lack skills on how to triage, and they also don't have a collaboration or teamwork spirit. This was indicated by the midwife to say that, I think the challenge from the ward is a shortage only, but on top of that, we have those who don't want to work. Like sometimes a patient needs assistance at the bed, the other nurse just ignore them and just disappears. And other midwives, they lack skills in managing the emergency obstetric emergencies. And the other one was attitude and behavior. It was stated that although some of them, they do know how to manage, there is an issue of attitude and behavior from the staff to staff in such a way that if I need help to assist me with managing this kind of emergency, one could just ignore you and just move on. So it seems like attitude interferes with how quality maternal health care should be provided to pregnant women. This indicates a need for protocols which will guide midwives on how to triage, support programs which could empower midwives and foster a blame-free, non-toxic environment. As we've mentioned in the results, that they are not supported as they want to be. So we need to rethink the healthcare service delivery priorities to enable a clinical environment that improves the provision of quality care in our maternity units. The study highlighted that triaging of expectant mothers is plagued with many challenges. But how do we move beyond those challenges and improve the quality care in maternity units? So we identify that we should not only addressing these challenges will not only improve the provision of care, but will also enhance the patient's experience and ultimately reduce maternal and perinatal mortality in Mpumalanga associated with avoidable or preventable factors. Thank you. For more information on the study, you can check it out on that journal. Thank you very much.
Thank you so much. Questions? Okay, looks like it was very clear. Okay, we have come to the end of the session that was where we learned a lot. We learned about ice. We learned about, I've forgotten some of the things, but actually we learned a lot towards advancing universal healthcare. All these things we are learning so that we may have solutions towards advancing universal healthcare. Thank you so much to you, the audience, and thank you presenters, and thank you my judges and the timekeeper for giving me the opportunity to lead you. It's bye for now.
Good afternoon, ladies and gentlemen. Picking up from where Prof. Chitangano has left it, we continue with the next session. That's the session for posters. Can I just check by show of hands if we have the following presenters? Sema Ramashala, AR. Thank you. Mahabu, T. Around. Moshole. Poshoko. I don't see Poshoko. Maunye. Sema Ramashala is here. Okay, let me find out if you have loaded your posters on the system. Did you load your posters on the system? If you have loaded, please, let's have Mr. Sema Ramashala, and the rest of us can go towards the table to load the posters so that we don't waste any time. Presenting you. Fine, thanks. You're the first presenter. Yes.
Dr. Zama, which one?
Which one?
This one.
No, the second one.
This one.
No, the first one will be the last one.
Oh, okay.
Yeah. You're starting with this one. This one. Yes, it has to go to this one. While we are waiting for the reflection, can we get the pointer, if you have the pointer? From the IT table, please, if you've got the pointer. Okay. It's fine. Let me introduce to you to Dr. Sema Ramashala on behalf of Rafumbezani MK and Morera TJ. She will be presenting a poster, Nodules in the Skin and Muscles, a case of disseminated cirrhosis with multi, that one, involvement. Yes. Thank you very much. You're welcome. Can I see the timekeeper? Please. Our 7 minutes starts now. Is it 7 minutes? Yes.
Okay, thank you very much, and good afternoon, ladies and gentlemen, colleagues, everyone. My name is A.R. Sema Ramashala, and I'm going to be presenting a case of nodules in the skin and muscles, which is a case of disseminated cysticercosis with involvement of many organs. Cysticercosis is a parasitic infestation caused by the larvae of the pork worm, which is acquired through consumption of measly pork. And the complications of this infestation depends on the site of involvement. We describe a case of widespread cysticercosis with involvement of the skin, brain, orbit, myocardium, and skeletal muscles, including the diaphragm and scrotum. A 51-year-old HIV-negative male presented to us with asymptomatic nodules affecting the skin of the arms, neck, and chest. And on examination, the patient had skin-colored nodules that affected the named areas. It was difficult to come up with a diagnosis because we had never seen this case before. So we thought of metastatic cancer and all those other conditions that present with nodules. Stools for ova and parasites were sent, and they were negative, and the test was negative. And the blood test for ELISA for the larval form of Tinea solium was positive. The skin biopsy that was taken, we did an excisional biopsy, showed a parasite. This figure here shows part of the skin and the parasite that actually popped out of the skin biopsy. The parasite is over there. And this is the close-up view of the parasite showing the typical features of Tinea solium. The CT scan of the brain showed involvement of the brain itself and also of the retrobulbar area, the area behind the eye. A whole body MRI, magnetic resonance imaging, revealed disseminated cysticercosis with involvement of the diaphragm, scrotum, among others. The patient was managed together with physicians. cutaneous soleum is it's an infestation that we see in Africa, in South America, and also in India. The infestation comes as a result of ingestion of measly pork. The implication of this is that there is an informal meat market that is throwing meat festivals where people consume measly pork. And in conclusion, consumption of the infested pork in public health is a public health problem worldwide. And this patient was asymptomatic, and that's why they presented 5 years later. And we recommend awareness campaigns and control of human waste, meat inspection, and also deworming of livestock. Thank you.
Thank you very much. A round of applause for him. Yes, already we have a hand up. Thank you. Questions?
Thank you so much, Doctor, for the presentation. I'm curious to ask this. You talk about eating pork. Is there scientific evidence linking that kind of condition with pork eating?
Yes. Yes, Prof.
Sure.
It's not eating pork per se, it's eating infested pork, pork that is infested with these parasites. So we need to inspect the meat before it's cooked. It should be inspected, maybe at the slaughterhouses. We need those health inspectors and also veterinary doctors to assist with inspection of the meat. Not all pork has the parasite. Thank you.
Thank you so much. Can she go? You don't have any other question?
I thought cooking the pork will kill the parasite, but I don't know.
Yes, Prof. It's mainly pork that hasn't been properly cooked. So this patient was a regular at a meat festival that takes place in the area. There's a market, a meat market that operates there, where these festivals are thrown and animals are slaughtered without any inspector in attendance to inspect the meat.
There's another hand. Can we take your hand, ma'am?
Thank you for the beautiful presentation, Doc. I just wanted to find out, how do you then treat the noodles, the skin condition?
Yes, we treat the skin condition with anti-parasites, like praziquantel that we have used in this patient. You can also use albendazole. But I would like to inform you that not everyone should do that. Don't encounter a patient with skin nodules and then treat with those drugs, because there's a likelihood, commonly, once you see nodules in the skin, it means the brain is affected. Commonly, the brain becomes the seat of all these nodules, and most of these patients then present with epilepsy. So when we treat them with this antiparasitic drugs, as these baby worms die in the brain, they trigger an immune response, meaning that now the body or your immune system recognizes the worm, the baby worm in the brain, and then mount an immune response. Those inflammatory cells then zone in on that focus of the cyst. you know, immune cells secrete all sorts of things, enzymes, cytokines, that destroy. So the brain becomes an innocent bystander. So those patients must be admitted and then given this treatment under close surveillance. That's why we give them steroids over and above the treatment. Thank you so much.
Thank you very much, Doctor. Can you please clap hands for her? Those who are staying in villages, please be careful when you slaughter those animals. Our next presenter, it's Makgabo T. Makgabo T on behalf of Mokoena M and Rushaka I. A hand of applause for him, please. Can you assist us with the reflection? Mashole LP, you are the next presenter. Can you make sure that your presentation is uploaded? Yes, the clock is ticking. Your 7 minutes starts now.
Good day, everyone. My name is Chawafajo Makgabo, and I'll be presenting to you about antimicrobial patterns of Escherichia coli in urinary tract infections at a tertiary hospital in the Limpopo province, South Africa. So, urinary tract infections remain one of the most prevalent bacterial illnesses worldwide, posing a major health concern, with Escherichia coli consistently identified as the leading pathogen and resistance rates varying dramatically by region. Nitrofurantoin, for instance, which is one of the common drugs used, shows low resistance of between 0 to 4.4% in some areas. So in South Africa, studies from KwaZulu-Natal reported substantial resistance in E. coli isolates to amoxicillin, which presented with a resistance levels of 16.8 to 19.5%, and ciprofloxacin standing at 15.2 to 21.7%, but lower resistance to cefuroxime and carbapenems. So the Limpopo province lacks such critical data, representing an urgent spot for empiric UTI treatment and public health planning. This study aims to fill that gap in order to improve prescriptions of antimicrobials for these infections. So, This study aims to investigate antimicrobial susceptibility patterns of uropathogenic E. coli from urinary tract infections and detect key resistant genes associated with resistance. So, moving on to methods. We used this study incorporated a prospective approach and a quantitative approach. We utilized convenient sampling using urine samples that were readily available. So we collected a total of 159 E. coli positive urine samples from the National Health Laboratory Services at Polokwane, amongst inpatients and outpatients from Petersburg Hospital. So we further performed identification, or prior to that we did a 24-hour incubation and performed identification and susceptibility testing using the VITEC system, and the results were as follows. Among the E. coli isolates analyzed, the resistance was most prominent within the beta-lactam class of antibiotics, where ampicillin exhibited the highest resistance rate, standing at 69.2%, followed by ceftriaxone standing at 25.8%, and amoxicillin standing at 3.8%. So carbapenem and colistin showed no resistance at all. So we furthermore, of the 159 E. coli colonies tested, 27, which represented 17%, were identified as extended spectrum beta-lactamases producers, underscoring a significance of resistance mechanism within the sample population. So what these results implies is that ampicillin resistance was particularly high, standing at 69.2%, which is consistent with the previous reports from South Africa and low and middle income settings where this antibiotic is widely used as first-line treatment. The moderate resistance observed for ceftriaxone and low resistance to amoxicillin suggest a differential activity across beta-lactam subclasses, highlighting the need for context-specific surveillance. Importantly, no resistance was detected to carbapenems, which include ertapenem, imipenem, and meropenem. Also, colistin didn't exhibit any resistance, underscoring their continued efficacy as reserve agents against multi-drug resistant E. coli. This research provides crucial data on antimicrobial resistant patterns of E. coli in the Limpopo province, enabling clinicians to make more informed treatment decisions and supporting hospitals in developing stronger antibiotic stewardship programs. So importantly, the molecular component of this project, which involves the detection of resistant genes, is still ongoing and will provide deeper insight into the genetic mechanism driving resistance in the region to improve treatment outcomes and guide health strategies. Thank you very much.
Yes, it's time for questions. If you have got questions for her. Going, gone. Thank you very much, Doc. A round of applause for her. The next presenter that we have on the list is Mashole. On behalf of Pasha D, Simelane D. while they're still busy with technology, just to remind you that we are in a session for communicable diseases. And the one speaking to you now is Dr. Mashamba, not Dr. Tau. I'm just standing in for Dr. Tau this afternoon. And the presenter is ready. Thank you. Your time starts now.
Greetings, I'm Moshalole Pesi. I'm here to present my study titled Hepatitis B virus seroprevalence in pregnant women in the Limpopo province. Now, hepatitis B virus is a DNA virus transmitted through exposure to infected blood and body fluids, and it contributes significantly to maternal complications, liver cirrhosis, and neonatal death. Lack of data in rural areas like Limpopo increase the risk of untraceable HBV spread, leading to serious health outcomes such as liver cancer and preventable death. The method that we used was quantitative and cross-sectional. So we used a HBV combo rapid test kit according to manufacturer's instructions to detect serological markers on remnant blood samples. So on the results, first we have table 1, which shows the HBV distribution per age group. We've got the age statistics, minimum, maximum, mode, and median. So the minimum is 21 and maximum is 38 years of age. Number 2, which is figure 1, shows the picture of a HBV test kit. As you can see, it shows the the interpretation of each and every serological mark. On table 2, we've got the stages of HBV infection amongst the study participants. Firstly, we've got HBV serology profile. We've got a number, percentage, and interpretation. Just to save time, I will use one example. First, we've got a surface antigen. We've got surface E antigen, which is, both of them are positive. And we've got a core antibody, which is positive. In the interpretation is that it is acute infection. On figure 2, we've got HBV status according to the age ranges. First, we've got those who are less than 25, they were all negative. And those who were who were more than 35 years of age, they were all negative. And between 25 and 35, few of them were found positive. Now on the discussion, the study involved participants aged 21 to 38 years and found an HBV seroprevalence of 10.6%, with 5.3 being chronic infections and 5.3 actively shedding the virus. About 5% had been successfully vaccinated, while 84.4 had never been exposed to HBV. The current 10.6 HBV serotype prevalence is comparable to the global chronic HBV infection prevalence of 0.1 to 20% reported by the study done by Levenke and Kane in 2016. Similar findings were reported in a Cape Town study with an HB surface antigen seroprevalence of 4 to 12% in HIV-negative pregnant women in rural areas. This was the study done by Davy et al. Individuals with chronic HBV infection are reported to have a 15 to 40% lifetime risk of cirrhosis, liver failure, and hepatocellular carcinoma. This was the study done by Spearman in 2018. Now, in conclusion, the current study reported a 10.6% HBV seroprevalence among pregnant women in Limpopo province, with concerning proportion actively infected or chronically affected. The low vaccination rate and high percentage of unexposed individuals highlight a critical gap in HBV prevention efforts. These findings highlight the need for improved healthcare planning, strengthened vaccination programs, increased awareness, and targeted interventions to curb the spread and impact of HBV. These are my references, and I would love to acknowledge, firstly, I would love to thank God for such an opportunity and to help me carry the study. I further extend my gratitude to my supervisor, Mr. Daniel Slimilani, and also my co-supervisor, Dimakazo Pasha, Yvonne Pasha, for your guidance and support throughout the study, and also acknowledge NHLS for samples. Thank you.
Great. Okay, thank you very much, presenter. Any question for him? Don't be scared. You just have to protect yourselves. Communicable diseases are a reality. So remember what he said. Thank you very much, sir. no question for you. Round of applause for him. Our next presenter, Poshoko. Poshoko is not around. Maunye J. Maunye J. Not with us as well. Then, oh, is he around? Oh, okay, a round of applause for him as he comes, please. Then. Maunye J, on behalf of Silichana O. Did you load up your thing? Okay. Yes, he is going to present to us molecular characterization of common neuropathogenic in catheter-associated urinary tract infections in Limpopo province, South Africa.
Yes, that's correct. It's fine, I'll just navigate on the laptop.
Thank you very much. The time starts now.
Good day, everyone. My name is this one. Good day, everyone. My name is Maunye Joy, and I'll be presenting my project titled Molecular Characterization of Common Neuropathogens in Catheter-Associated Urinary Tract Infections in the Limpopo Province, South Africa. So without any further ado, let's get into it. Urinary tract infections, or UTIs, have an increasing prevalence globally, with a notable increase of 60.40% from 1990 to 2019. So this prevalence has been significant in the African sub-Saharan region, with South Africa reported the second leading country. One of the major risk factors for this prevalence is urinary catheterization. As a result, catheter-associated urinary tract infections continue to be at the top of the list of most common nosocomial infections. So to the best of our knowledge, there aren't studies or enough studies exploring the causative agents of these catheter-associated urinary tract infections in the rural province of Limpopo. Moving on. So once again, our study aimed to determine the most common uropathogen from culture positive samples, and determine or try to detect its virulence patterns or virulence genes that enhance the pathogenicity of the most common uropathogen that we would find from these positive samples. So moving on to our methods, our study employed a prospective cross-sectional design with convenient sampling, and the study was conducted at the University of Limpopo Medical Microbiology Lab and the NHLS in Polokwane, the NHLS Medical Microbiology Lab in Polokwane. Okay, so these are just the diagram, the flow diagrams which indicate the data collection from isolation of the uropathogens or the bacteria causing the catheter-associated UTIs, from confirming identification and confirmation of these causative agents using the Vitex system, and the last diagram showing the flow diagram for detection of the most of the common genes in the most commonly found uropathogen. So moving on to results. So isolates from 215 positive samples of catheter urine have been obtained from the lab, the NHLS lab, and initially were stored in glycerol or TSB stocks, and awaited for the molecular characterization part, with this the detection of the virulence genes in the most common uropathogen. So the most prevalent uropathogen was found to be E. coli, accounting for 84 occurrences, and followed by Klebsiella pneumoniae, accounting to 38 occurrences, followed by Enterococcus faecalis. This is just a pie chart representing our findings, or representing the distribution of these uropathogens. On the detection of virulences, or on the molecular part of our study, 4 genes that are among the most common genes, among the most common virulent genes associated with the E. coli, namely the type 1 fimbriae, pyelonephritis associated pili, or the PEPC, and the S and F1C fimbriae, or the SFA, and the irobactin were detected by the PCR and visualized by gel electrophoresis. These are just figures showing the visualization or the detection of these genes. The first diagram just showing the optimization of the protocol when we're still trying to develop a protocol for this detection of these genes. And as you can see, it's not showing properly. And picture B represents the perfect. That's when this picture was when we have found a perfect protocol for the detection of these virulent genes, which it represents the 3 genes, namely the PAPC, FIMH, and the SFA, and the last picture showing the last gene, which is the irobactin. And the below graph showing the distribution of virulence genes among the culture positive urinary tract, the uropathogenic E. coli. Okay, so I've realized I've run out of time, so I'll just move to discussion and conclusions. So the study highlights the predominance of E. coli as the most common uropathogen within the Limpopo province, followed by the Klebsiella pneumoniae and the Enterococcus faecalis. The identification of these pathogens underlines their important role in catheter-associated urinary tract infections in these regions. And again, we found that the FIMH gene was found to be the most present virulence gene, which is comparable with other studies worldwide. This shows that the uropathogenic E. coli uses the FIMH as the major virulence factor for colonization. So lastly, targeting the FIMH gene as a vaccination candidate is crucial for the prevention of UTIs. This was the conclusion. So just say this one last statement. Ongoing molecular characterizations of virulence factors will provide critical insights into the pathogenic mechanisms, which might be essential for guiding targeted infection control strategies and improving patient outcomes in these healthcare settings. Okay. Thank you very much.
Thank you so much. A round of applause for him. Hey, the way he was running so fast. I only picked up the fact that catheters are important. when the patient cannot do it on his own or her own, isn't it? Thank you very much. Any question? Question for him? No question for now. Thank you very much. Yes. Our last presenter, we'll have to bring back Dr. Sema. Dr. Sema, please. On behalf of Molapo RA, they are coming up with a different topic this time. De novo histoid leprosy, mimicking something. Thank you very much, Doc.
Okay, thank you so much. Good afternoon again, colleagues.
Can you please assist?
Okay, so thank you very much. I'm presenting a case of de novo histoid leprosy mimicking Xanthoma disseminatum in a Malawian male. Histoid leprosy is a very rare variant of leprosy that differs from regular leprosy clinically and histopathologically. Usually, the clue to the diagnosis of histoid leprosy is when the patient gives a history of leprosy having been treated or having been partially treated for the infection. But in this case, the patient presented with lesions that looked like histoid leprosy, but there was no history or treatment of leprosy. The patient is a 35-year-old HIV negative male from Malawi, presented with a 2-year history of asymptomatic skin lesions. Occasional epistaxis was also part of the complaint. On examination, the patient had nodules in the mouth, the palate, the vermilion border lips, on the neck, on the scalp, hands, feet were also affected. The differential diagnosis was Xanthoma disseminatum and histoid leprosy. All these lesions arose from normal skin. The clustering of lesions in certain areas, oral lesions, and lesions on the palms and soles gave us a picture of Xanthoma disseminatum. To diagnose leprosy, a skin biopsy was taken where the histopathology looked more or less similar to Xanthoma disseminatum, but the stain for leprosy was positive, a diagnosis of de novo histoid leprosy mimicking Xanthoma disseminatum was made. De novo histoid leprosy is very, very, very rare. This could be the second case of histoid leprosy in South Africa in a patient who originated from Malawi. Treatment of leprosy is multi-drug therapy, provided by the WHO. It is very important for clinicians to differentiate cystoid leprosy from other clinical conditions. This case shows us that the patient may have been misdiagnosed for him to present 2 years after the onset of the lesions. The rarity of de novo histoid leprosy is resemblance to Xanthoma disseminatum, and also its unique features may confuse clinicians to make a proper diagnosis, and therefore delaying treating this patient and also indirectly adding to the spread of the infection. In conclusion, we presented a second case of de novo histoid leprosy from Malawi. De novo histoid leprosy can be missed by clinicians because it can simulate other skin conditions like XD. I have put together here a table that shows the similarities and differences between the two conditions, and the main point here is to do investigations to confirm XD or histoid or de novo histoid leprosy. The remarkable features in this patient that mimic Xanthoma disseminatum are as we have seen in the pictures. And that brings me to the end of the presentation. Thank you.
Thank you very much, Doc. Can I please invite questions for her before she leaves? There's a hand at the back.
Thank you very much, Prof. There's something interesting about these two cases. I just wondering why Malawian males. Is there something specific, or why Malawian? I'm not sure.
I don't understand the question. Are you asking about why I mentioned Malawian, or are you saying why is it affecting Malawians? I don't understand the question. Can you clarify?
Why is it affecting only Malawians? Because you said it's only 2 cases, and both of them, I guess, they're from Malawian males.
Oh, okay. So I cannot say that it is affecting only Malawians because it's possible that it is being missed somewhere in our South African citizens. It's possible that it's being missed.
Okay, thank you, Doc, for the lovely presentations. My question is on the issue, the comment that you made. You said professionals should be alert with other similar conditions. What are the differential diagnoses of the condition? What are other similar conditions that one can have as a differential diagnosis? Thank you.
Okay, so apart from Xanthoma disseminatum, eruptive xanthomas, because of the yellowishness and creaminess of the lesions, if I may say that, they mimic xanthomas, meaning all xanthomas which present with nodules. Metastatic tumors, we thought that we could also be doing with a metastatic tumor in this patient. Nodular histoplasmosis. Histoplasmosis is a fungal infection that has many different clinical expressions. It can express itself as nodules, especially in HIV-negative people, individuals. So there are many other, conditions. Even the condition that I have just presented, the cysticercosis, it presents with nodules. So it can mimic many other conditions. So you need to have that to keep that, high index of suspicion.
Thank you very much. Let us just pray that these conditions should not appear here in South Africa. Otherwise, thank you very much. I'm signing off, handing over to Pramaboya to continue.
Good afternoon, colleagues. We are moving back to oral presentations. We have learned of skin conditions which also affect the mind. Now we are going to learn on how our minds can heal. Hence our theme is mental health promotion. I'm Prof. Ramaboya TI from the Department of Nursing Science. This session is going to be short. It's only 2 presentations from our presenters. So I want to know from our IT, is everything ready that side? Okay, thank you. Are we having our presenters Mubango, K, and Mola K, I? Okay, thank you. Just a reminder, you will have 10 minutes for presentation, which will be followed by 5 minutes of questions and answers. Thank you. Yeah, it's oral. The second one, and the first one is Mubango. Mubango, your presentation, we don't have it here. Can you kindly send? Oh, she's sending there. Okay, in the meantime, while she's still sorting herself, can we have Mola KJ to come and present for us? Let's clap hands for her, please, while she's coming. She's not around. Thank you. Let's give her a clap of hands again to encourage her. Thank you.
Today, I want to shed a light about one of the most critical issues that oftentimes go unspoken, and that is mental health struggles in children with epilepsy. What if mental health support was an integral part of epilepsy care in children with epilepsy? I stand here today not only as a researcher, but rather as a representative of children with epilepsy who have co-occurring mental health conditions, seeking to amplify their voices and improve their care. My name is Mona Kumujo, and I'll be taking you through my thesis, which is titled A Mental Health Intervention Program to Support Children with Epilepsy and Selected Public Hospitals of the Limpopo Province. As we consider breaking down the silence about mental health in children, it is also crucial to understand the scope of this issue. Globally, 30 to 50% of children with epilepsy develop mental health disorders. And according to the World Health Organization reports, 10% of these cases go undiagnosed and untreated. Shockingly, in South Africa, 90% of children lack access to mental health services, which reveals substantial care gaps. Building on this, children with epilepsy face significant mental health struggles, and that includes cognitive impairments, ADHD, anxiety, and depression. And despite existing mental health policies that are put in place in the country, there is poor implementation due to lack of insights that contributes to inadequate care. The Limpopo province faces additional obstacles, which includes a lack of a child psychiatrist and limited integrated care, which exacerbates mental health issues in children with epilepsy. Given the need for mental health support for children with epilepsy, the main aim of the study is to develop and validate a mental health intervention program to support children with epilepsy in selected public hospitals of Limpopo province. The research question that guides the study is, how can a mental health intervention program to support children with epilepsy in selected public hospitals of the Limpopo province be developed and validated? To answer this research question, the study's objectives have been divided into 3 phases. Phase 1, it is the integrated literature review, which its objective was to identify factors that need to be taken into account when developing a mental health intervention program. The second phase is the empirical phase, which is further divided into 3 steps. Step 1, it is the qualitative trend, which its objective was to explore the experiences of caregivers and healthcare workers caring for children with epilepsy in selected public hospitals of the Limpopo province. Step 2, it is the quantitative trend, which its objective is to assess the knowledge and the attitudes of caregivers and healthcare providers towards epilepsy in children. Step 3 is the integration of results, which its main objective is to integrate the experiences of caregivers and healthcare providers with their knowledge and attitudes towards epilepsy. The third phase is the development and the validation phase, which its objective is to develop and validate a mental health intervention program to support children with epilepsy. Moving forward, the study adopts a pragmatic paradigm using mixed methods approach to gain a comprehensive understanding of the topic. A mixed method approach using an exploratory sequential design was employed in the study conducted in Mankweng and Polokwane tertiary and academic hospitals. The integrative literature review, which is phase 1, has revealed contextual gap within the African continent. In a scoping review that was done in Africa, it was found that 14 countries in the past 30 years have had no research publications about epilepsy in children, making it difficult to develop a contextual intervention-based intervention. Sorry about that. The integrative literature review further revealed certain factors that need to be taken into account when developing a mental health intervention program, and that includes the social factors, systemic issues in our healthcare institutions, the family dynamics, and as well as the cultural beliefs that hinder support and care. The second phase is the empirical phase, the qualitative trend, which is step 1. The population for this trend was caregivers and healthcare professionals who are directly involved in the care of children with epilepsy, and that included professional nurses and pediatricians. The study participants were sampled using people self-sampling, and a pilot study was conducted using 2 caregivers of children with epilepsy, 2 professional nurses, and 2 pediatric medical officers in Mankweng Hospital. Data was collected using in-depth interviews with 21 participants until data saturation is met. The data was analyzed using thematic analysis. It has to be noted that this study is still ongoing, and data has been collected and analyzed, and findings revealed that caregivers reported that there are challenges related to the child's epilepsy, which included hyperactivity, aggression, self-harming behaviors, and educational disruptions due to seizures and behavioral outbursts. Professional nurses reported challenges in managing children with epilepsy, and that included inadequate resources and infrastructure and lack of psychosocial support for children with epilepsy, while pediatricians face diagnostic and referral challenges. The second step is the quantitative strand, which is currently underway. The population for this strand is caregivers and healthcare professionals, and that includes professional nurses, pediatricians, social workers, and psychologists. And the sampling for this strand was total population sampling, and pilot study will be conducted using 2 caregivers of children with epilepsy, 2 professional nurses, 2 pediatric medical officers, 1 social worker, and 1 psychologist in the Polokwane Hospital. Data will be collected using a self-designed questionnaire, and data will be analyzed using the SPSS. Step 3 is the integration of results, wherein the researcher will be integrating the qualitative data plus the quantitative data using the FETA, Carey, and Krasos 2013 framework for integration and mixed method research. The mental health intervention program will be developed using the Dieckhoff et al. 1968 practice-oriented theory, which incorporates 6 concepts that are interrelated, and that includes the agent, which are healthcare providers, the recipient, which is children with epilepsy, the context, which includes the social context, the healthcare environment, and the family dynamics, and the dynamics wherein now the researcher will be able to examine the relationships between the agent, the recipient, and the context, which will eventually lead to the development of the procedure, which is the mental health intervention program itself. The ultimate goal for this is to improve the mental health outcomes of children with epilepsy, which will enhance their quality of life. The mental health intervention program will be validated using the FUSET and DeSanto-Madias framework, which will be applied through a Delphi technique involving a panel of experts, pediatricians, professional nurses, psychiatrists, psychologists, and social workers. The panel experts will participate in a structured and iterative process wherein they will provide their feedback about the mental intervention program and also their opinions about their individual opinions about the program. Wherein now they collect the feedback will be analyzed until a consensus has been reached. The researcher took steps to mitigate bias in the study by having a representative population, which was selected, and the study utilized total population sampling and ensured bracketing knowledge, standardized questions, and ensured accurate documentation to reduce bias. Ethical clearance was obtained from the TREC, Limpopo Department of Health, Mankweng and Polokwane hospitals, and also the participants provided informed consent, and codes were used to maintain confidentiality during the qualitative data analysis. The study's significance lies in its potential to inform evidence-based practice, benefit the Department of Health by identifying gaps in the care of children with epilepsy, informing policies, and eventually improving the children's health outcomes. In conclusion, the study highlights significant challenges faced by children with epilepsy, including mental health problems, behavioral issues, and educational challenges. Key findings reveal gaps in psychosocial support, inadequate resources and infrastructure, diagnostic and referral challenges, which align with the existing literature. These findings will inform the development of the mental health intervention program. I thank you.
Thank you, Ms. Mola. Let's clap hands for her again. Questions for her from the presentation? Any questions? Seeking clarity questions from the audience?
Thank you for such an insightful presentation. I just want to find out, is this the proposal? Because I heard you said we will conduct a pilot study, we will. But at the end, I heard you presenting the findings and the gaps. So I just want to clarity based on that. Thank you.
Thank you for the question. To clarify that, the study consists of 3 phases. of which the second phase is the empirical phase. The first step was the qualitative strand, of which I had already conducted data and I just reserved results from the independent coder. So the second step hasn't yet commenced, so hence I was saying I will, with regard to the pilot study.
All right, thank you. I've got only two clarity-seeking questions. The first one is, currently are there programs that, I think there are programs that are currently there on Department of Health with regard to epilepsy. How is this one going to be different from them? And then the second one is, how are we going to maintain rigor on quantitative, and then how are we going to maintain trustworthiness on qualitative?
Okay, thank you for the questions. To answer the first questions, yes, there are programs that are put in place currently, but when I went to collect my data, it was found that these pediatricians find it difficult to offer psychotherapy to those children because they stated that they do not have a child psychiatric at the moment, and also a pediatric neurologist who are believed to be at the forefront of this psychotherapies. And to ensure trustworthiness, I've also indicated that the study has utilized codes during the qualitative data analysis.
Thank you so much, Madam. Thank you so much. It's a follow-up to what he has indicated. If there are any programs that are in place, why do you reinvent the wheel? Why can't you just do an additional or improve on what you have? Because you are going to develop a new strategy which will be used. So is there no any other strategy currently? If they are there, why do you want to develop the other one?
Okay, thank you very much for the question. I think we'll look into that with my supervisors. Thank you for the comment.
We'll be taking our last hands. If there are other hands, you will have to consult with her. Thank you.
Thank you, Chair. I just want to ask, you said this is a mixed method design. Specifically which one, and depending on your response, how is this data that you have already collected forming a baseline to the phase of quantitative? Because you said you've got data already on qual. So depending on that design of your study, how is this information informing the next phase? Thank you.
Thank you very much for the questions. This is an exploratory sequential design. As I've already stated, it has started with the qualitative strand, which will lead to the quantitative strand. Data from the qualitative strand will be used to develop the questionnaire.
I thought I said this is the last hand.
You mean the question, that question is not yet there? Is that what you're saying?
The question is not yet there because I just reserved the results from an independent coder. Data, I haven't yet discussed the study findings.
Thank you, colleagues. Is there anything like burning question? Oh. Okay, thank you. Thank you, Emola, and continue good work. Is Mbango around? No, in the absence, I think we are done with this session. Thank you, colleagues.
Hello, colleagues. My name is Milan Maringa. I'll be the chair for the next session, but allow me to confirm with him if we do have the slides for these presenters. So in the meantime, while it's taking, allow me to welcome you to this session. And then it's of great pleasure that you are still here. It shows commitment to sharing, advancing knowledge, and also sharing ideas. Okay? So please allow me to go through the are going to be presenting for this session. And just by show of hands, please tell me if you are in. It's Maibelo ML, Mujapelo MJ, Mukhele BM, and then Rapohle. Sorry for the pronunciation. MJ. Are you all here? Okay? It's okay. So, with that said, please allow me to welcome the first presenter by giving him a round of applause while he ascends the stage. Thank you.
Is it edited?
Yes.
This one is easy. So if I use this one or this one. Which one is it? It's the right one.
So please participate actively, and you also listen actively. I'm just giving him a chance for stage fright so that it doesn't. Please listen actively, and also make notes for enhancing the discussion at the end of his presentation.
Good afternoon, ladies and gentlemen. I'm Maibelo Magale. I'll be taking you through the study presentation titled Assessing the Synergistic Effects of Cannabis sativa and casomine on MRSA and Candida albicans for antimicrobial activity. Antimicrobial resistance occurs when bacteria, viruses, fungi, and parasites change over time and no longer respond to the available medicine. Casomine is a bioactive compound derived from turmeric, and cannabis is a bioactive compound derived from cannabis sativa. The picture here, this part shows the cannabis sativa. The top part is our casomine. Methicillin-resistant Staphylococcus aureus is a type of bacteria that is resistant to several antibiotics, including methicillin. Candida albicans is a virulent pathogenic fungus that inhabits half of human oral cavities and can cause opportunistic infections, particularly in immunocompromised populations like HIV or AIDS. Problem statement: methicillin-resistant Staphylococcus aureus and Candida albicans cause severe hard-to-treat infections due to their resistance to existing treatment, creating a global health challenge. Casomine and cannabis sativa have shown some potent antibacterial and antifungal effects when used with other agents in a combination therapy, and our research investigated this synergy against microbial resistance. To the best of our knowledge, there are no published studies about the effectiveness of cannabis sativa and casomine in synergy. Purpose of the study aims to assess the synergistic effect of cannabis sativa and casomine on MRSA and Candida albicans for antimicrobial activity. The objective of the study are to prepare extracts of cannabis sativa using methanol to test the susceptibility or resistance of MRSA and Candida albicans to cannabis and casomine in synergy. The research design, the study used was experimental, quantitative, and prospective study. Convenience sampling method was used. Semi-dried cannabis sativa strains were purchased from a cultivation farm with a cultivation permit number. Commercial procured casomine was stored at 4 degrees Celsius fridge. Cannabis extract were semi-dried and were crushed and weighed, soaked in methanol at a ratio of 1:10, then placed next to shaking incubator and filtered, then allowed to evaporate. The extract were reconstituted with DMSO, preserved at 4 degrees until further processing for antimicrobial activity. 2 multi-drug resistant microorganisms isolated from clinical samples were obtained from NHLS Polokwane Hospital, which are methicillin-resistant Staphylococcus aureus and Candida albicans. Antimicrobial assays which were employed is this diffusion and KB-Bio method. Table 1 shows the activity of casomine and cannabis sativa in synergy for MRSA, and the zone of inhibition was measured. Table 2 shows the MIC of casomine and cannabis sativa in synergy for MRSA. Three tubes were susceptible and 5 tubes were resistant. Table 3 shows the relationship between the MIC and inhibition zone for synergy of cannabis sativa and casomine on MRSA. Table 4 shows the independent t-test result with a p-value of 0.135. Comparison of zone diameter samples. For cannabis sativa and casomine in synergy, the mean for susceptibility was found to be 58.63 with a standard deviation of 38.38. For resistance, the mean was 4.87 with a standard deviation of 4.79. A p-value of 0.135 was found. Implication of the findings: the results showed an effective antimicrobial activity of casomine and cannabis sativa extract in synergy against MRSA. No antimicrobial activity was observed on Candida albicans. The casomine concentration used in this study might have been low to inhibit the growth of Candida albicans. In another study, it was found that casomine works well in synergy with other medicinal plants as an antimicrobial agent than when used alone. In conclusion, the demonstrated antimicrobial activities in the cannabis sativa extract and casomine in synergy have provided an overview of their potentials as antimicrobial agents against MRSA in synergy in this study. Further studies are needed to confirm efficacy and safety of cannabis sativa and casomine in synergy for the treatment of MRSA-related infections. In conclusion, the use of different natural antimicrobial agents in synergy seems promising in terms of overcoming microbial resistance and increasing the efficacy. The study limitation was Aspergillus flavus could not be sourced from NHLS, and Candida albicans was used as a substitute. Since Candida is a yeast and Aspergillus is a mold, the two organisms possesses distinct resistant profiles which may have limited the conclusiveness of the findings regarding antifungal activity. Also, the concentration of casomine used may have been insufficient to demonstrate its previously reported antifungal effects, as its activity is known to be dose-dependent. Future studies should directly evaluate the synergistic antimicrobial activity of cannabis sativa and casomine against Aspergillus flavus as initially intended. In addition, high concentration of casomine such as solubility enhanced preparation should be tested to overcome its poor bioavailability. Expanding the microbial spectrum to include a wider range of bacteria and fungal pathogens, particularly multi-drug resistant strains, will provide broader insight into the therapeutic potential of this combination. These are my references. I thank you.
Well, thanks for a very insightful presentation. I would like to take some questions for him from the floor. If you have questions for him. Do you have questions? No questions? Seems like I have to multitask.
Thank you, sir. So my question relates to how you extracted your plant components or phenolic components. You mentioned that you used methanol. So my question relates to why did you use methanol, or what informed your choice of using methanol maybe instead of, for instance, distilled water? And could there be a possibility that the component that you used to extract this plant affected its ability to perform the sort of the medicinal effects that you were looking for? Thank you.
Okay, thank you for the insightful question, sir. About using the methanol as to extract my plant, is because methanol is said to be it assists in extracting more of the compounds in the cannabis sativa than when using distilled water. And again, as I mentioned that for the results, for us not to find any result on Candida albicans is due to that it's a yeast, and the study actually at first intended to use Aspergillus flavius, which was not found.
Are you satisfied with the answer? Any other question? One last round. If there are no questions, there's one there.
Thank you so much for a lovely presentation. I think that was very interesting. I'm just curious if the methanol that was used, didn't it have any impact on the curcumin that were extracted, and perhaps it affected the results? And would you recommend that in the near future, in terms of dietary, should we recommend usage of these antimicrobial plants, such as like herbs, variety of them, on a higher dose or just middle?
Thank you very much, ma'am, for the insightful question. About the cytotoxicity of these medicinal plants, it was not really part of the scope, so me and my research mate will look into it.
Okay, can I protect him now and allow him? Okay, let's give him another round of applause. Okay, and our next presenter is Mujapelo, MJ, with the title as follows. It's Medicinal Benefits of Optia ficus indica, and then antibacterial and immunomodulatory activities. May you please ascend the stage and give her another round of applause. Okay, ma'am, the floor is yours.
Good afternoon. I am Mujapelo MJ, and I'll be honored to share my research on the determination of medicinal benefits of Opuntia ficus indica, focusing on its antibacterial and immunomodulatory activities. So in simple terms, my study will be testing if these traditional medicinal plants, they have a potential effect to fight bacterial infections and also boost the immune system. So antibacterial resistance is a grave global public Antibacterial resistance is a grave global public health issue that is endangering the progress that is made in modern medicine. So the overuse and the misuse of antibiotics have made this bacteria to be smarter in terms of adapting and surviving by means of mutations, making like those life-threatening diseases more difficult to treat. Like we thought they were treatable with antibiotics, but resistance is a rising issue. Hence, there will be an increased risk of illnesses and the transmissions, and also an increased rate of mortality. So scientists are looking back into the traditional means, like can we use these traditional medicinal plants as alternatives for antibiotics? That's where comes in our plant of interest, which is Opuntia ficus indica, commonly known as prickle pear. So these plants can be found in various parts of Africa and also South Africa. It has been reported for use in traditional medicine for years to treat various health purposes. To name a few, it has been used for chronic pain relief, anxiety, and also sleep sleep disorders, yes. And then also it has been documented that it may possess some anti-inflammatory and antioxidant and possibly anti-cancer activities. So our pathogen of interest in this study was Escherichia coli, which is displayed in figure 2. And most people, they know it as a cause for food poisoning. And also this E. coli, it is also associated with diarrhea, urinary tract infections, pneumonia, meningitis, kidney failure, to name a few. So people can get exposed to E. coli when they drink contaminated water and food. It can be undercooked beef or raw veggies. And then also the current treatments for E. coli, it's been reported that they've been using ciprofloxacin, azithromycin, and rifaximin, to name a few. And then resistance is still a rising issue. So we are not only testing these plants for their antibacterial activity, but we are also looking at their immunomodulatory activities. So immunomodulation, it refers to altering the immune response in the sense that it can suppress the immune system in case where there is an overreactive or an increased inflammation, or it can stimulate the immune system in the sense that it's going to boost the cells. So in my study, I focused on two key cells of the immune system, our neutrophils and lymphocytes. So as we all know, neutrophils are our first responders. They're the ones that rush to the site of infection in the case of bacterial infections, and then they kill this bacteria directly by means of respiratory burst, where they're going to release their NO and reactive oxygen species. So the lymphocytes, they are used for adaptive immunity, and they provide a long-lasting defense in the sense of memory. So moving on to our objectives, we determined the antibacterial activity of Opuntia ficus dichloromethane extract against E. coli, the effect of this extract on lymphocyte proliferation, and its neutrophil immunomodulation through reactive oxygen species and nitric oxide production. So I'm going to take you through how we conducted our study. Firstly, our plants were collected from the University of Limpopo, grounded into powder form, and we extracted using dichloromethane as our solvent in the process of maceration. And also the antibacterial activity was determined using rizazorin as the measure of cell viability. And then with lymphocyte proliferation, we use WST8 assay, which measures the cell metabolism of the lymphocytes. And in the case of neutrophils, In ROS production, we assessed using fluorometric assay kit, and NO production, we use grease reagent. So we analyzed our data using the GraphPad Prism version 9.51, and we measured significance using the one-way ANOVA test. And then now I'm going to take you through our findings, and then these results, they're going to be expressed as the mean percentage by the test agents, ranging from 15.625 to 500 microgram per ml. So the results were considered to be significant since our p-value was less or equal to 0.05. The first results, we have antibacterial activity, where we tested this extract against E. coli, and we used ampicillin as our positive control. So at low concentrations, there was like little to no inhibition of this E. coli, and then as the concentration increased, we saw like a significant inhibition of bacterial proliferation. And we're going to move on to lymphocyte viability, where we used LPS as our stimulant, and we treated these lymphocytes with our extracts, and then at low concentration, we observed like a little proliferation of lymphocytes, whereas as the concentration increased from like 125 microgram per ml to 500, there was an increased proliferation. Moving to reactive oxygen species production. So also like it has the same trend, but in this instance we used PMA as our stimulant. At high concentrations we have an increased production of this ROS. And then moving on to our nitric oxide production, a stronger production was seen also at higher concentrations, and PMA was also used as our stimulant. I'm going to take you through the limitations of our study. We used high effective concentrations. As we have seen in our results, it was a dose-dependent response, like at high concentrations. So high concentrations, they can be toxic when we take this study in vivo. Like the human system, the humans, like we can find it as toxic. And we also use like crude extract, meaning like this plant, it was not purified. It contains multiple compounds. Like we do not know which ones like exactly were active in this instance. We also, this study was conducted in vitro, meaning sometimes the transition from vitro to in vivo, like it cannot be exactly the same. And in my study, I used a non-polar solvent only, meaning like I did not focus on the polar side of the bioactive compounds found in this plant. So to conclude, at high concentrations, Opuntia ficus indica leaf dichloromethane extract did inhibit E. coli growth. It stimulated the lymphocyte proliferation and also enhanced the neutrophil ROS and NO production. So in summation, this extract can be explored further for its bioactive compounds to develop medicines to treat infections caused by E. coli. And then in the next slide, I have my references. And then I would like to acknowledge my supervisors and fellow students for their guidance and support in this study. Thank you all for your attention. I'll be happy to take any questions.
Do you have any questions for her? Let's engage her work as a token of appreciation. At least one question or two. Yes.
Thank you very much for such a wonderful study. I just want to know, isn't it indicated that the plants that we're using, where you're trying to find again those antibiotics that they form resistance when the patient take. So I want to know whether after you have done this study, did you find that those who were taking these plants, they were not resistant to either one of your plants? Thank you.
Thank you for your question. Our problem is that the study was conducted in vivo. We did not have any participants. So we based our research on like the literature that was there, like about drug resistance. So we opted for medicinal plants.
Any other? I just recognized you.
So I saw that you said there was proliferation of neutrophils and other, I don't know what blood, how did you measure that?
The nitric oxide and ROS. You're referring to ROS?
No, you said the medicinal activated your immune system, and you showed that by the increase in the neutrophils. I don't know what else you said. Did you say, so how did you measure it?
With lymphocytes, they're the ones that they proliferated. So we use the WST8 assay. It measures the metabolism of those cells. So as the cell viability increases, there is going to be a reduction in that dye. So we're going to see a color change. And then we used a 96 well plate, and we measured the absorbance at 540. So at high absorbances, that's where we could tell whether there was a proliferation. And in the sense of ROS and NO, for ROS, since we used, I don't remember if it's Chris reagent, we measured the nitrite. Like if we measure the nitrite production, nitrite, it reflects NO production.
Okay, any other before I can close? Just the last hand.
Thank you, sir. Thank you for your presentation. I'm a layman with regards to this. My question is very simple. Is this, are these extracts already being used as form of the traditional medicine? And out of public concern, what should we know? Because already you are highlighting the fact that at high concentration, this can be quite toxic.
Based on previous literature, yes, the plants have been used. We have been seeing Opuntia ficus indica has been used for treating kidney failures, chronic pain reliefs, but I'm not sure as to where like people can just, when you have a certain disease, maybe you know you have E. coli, you can just go get Opuntia ficus indica because it is easily accessible, because we don't know if there are any toxic compounds in that plant that are going to affect your immune system, so that can still be tested.
Bringing it home, what is this? I'm from the university, I'm from the surrounding, and I was brought there. So how should I understand this? What tree is that in my mother tongue, maybe, if I should say?
Motor. Do you know motor? It has like
Thank you,
thorns.
thank you.
Yes.
I know, she's on fire. She knows the story very well. Yeah, you can. So our next presenter will be, I'm not too sure if you have already loaded your slides. It's Mokhehle, BM. Are you around? Okay. You may ascend the stage. Let's give her a round of applause as she comes. So title is as follows: chronic kidney disease in South Africa, scoping review of epidemiology, challenges and future directions.
Good afternoon, everyone. I am Mokhetle Belinda, a PhD candidate in public health. I'm supervised by Professor Chitangano. The title of my project is Chronic Kidney Disease in South Africa, a scoping review of epidemiology, challenges, and future directions. This is the outline of my study, my scoping review. Chronic kidney disease has emerged as a major public health challenge where it affects an estimation of 850 million people globally. It is a very serious public concern whereby in sub-Saharan Africa, it is driven by both the communicable disease and the non-communicable diseases, which includes HIV, tuberculosis, the hypertension, diabetes, and obesity, which causes the kidney damage in patients. In South Africa, the estimation vary wildly depending on the study design and population, where it ranges from 6% to 17% in adults, with a substantial high rates observed among high-risk groups, as mentioned above, HIV and diabetes, hypertension. CKD accounts to 6 to 10% hospital admission in South Africa, in South African tertiary centers, and it imposes substantial healthcare costs due to dialysis and the kidney transplantation needs. Against this backdrop, a comprehensive understanding of CKD in South Africa is critical. While several studies and registry reports have described aspects of the burden, risk factors, the treatment access, and evidence remains fragmented. The aim of this scoping review is to map the available literature on CKD in South Africa, providing an overview of prevalence, risk determinants, access to kidney replacement therapy, and the policy implications. The objective of this scoping review is to identify the knowledge gaps and to inform the future research and health system responses. The scoping review used the following methodology, whereby the search strategy used was the PRISMA guideline of 2020. We searched using the PubMed, Scopus, Web of Science, Google Scholar for studies published between 2010 and 2025. The keywords that we used when searching for this literature included the chronic kidney disease, South Africa, epidemiology, risk factors, management, dialysis, transplantation, and national health insurance, whereby the Boolean operators and/or were used to combine the terms while searching for literature. The eligibility for this scoping review, in the inclusion criteria, we used both the primary research and the reviews. Then the studies that reported the CKD prevalence were included. The studies that reported about the risk factors of CKD and the management practices of CKD and the policies in South Africa were also included. And this scoping review excluded the case reports, the non-peer-reviewed sources, and the pediatric nephrology studies. While searching for literature, we found 520 records, whereby 70 of literature was duplicate, then it was removed. Then we were left with 450 records, where myself and my supervisor, we screened those records. Then we found the full text articles, which were meeting the eligibility criteria. They were 120. Then the studies, finally, we reached a consensus whereby we only included 45 studies in this scoping review. Then by so doing, the results of this scoping review mentioned that the prevalence estimate of CKD in South Africa ranges from 6 to 17% in adults. And the estimation of this CKD prevalence depended on the population being studied. The prevalence is high in high-risk groups, particularly in people living with HIV and those with diabetes and hypertension. The CKD accounts to approximately 6 to 10% of hospital admissions in tertiary centers of South Africa. The prevalence of CKD in South Africa, according to the provinces, whereby we focused on the studies that were done. Like for instance, in Limpopo province, a cross-sectional study was done in people living with HIV, where we found that the prevalence of CKD was 7%. Then in the Northwest province, the population-based survey found the prevalence of CKD in 33%. Then in Mpumalanga province, the population-based cohort gave us the prevalence of 10.7%. Free State province, the study was a home-based audit where it gave us a prevalence of 25% in clinic population, where the type 2 diabetes patients were part of the study. Then in the Northern Cape, we relied on the registry report, whereby minus 125 per million of patients treated for end stage of kidney disease. Not only the prevalence, but the end stage of kidney disease were found to be on that level, according to the provincial dialysis and transplantation registries. Then in Western Cape, a cross-sectional study survey was done. Then it gave us 8.7% and 6.4% in another urban area, where it focused on the general adult population. In Eastern Cape province, a cross-sectional study was done. Then the prevalence rate was 17.2% in the rural community of Mbengweni for outpatient attendees. Then Gauteng province gave us an estimation of 10 to 12%, where it estimates based on a high diabetic patient burden. Then in KwaZulu-Natal, the estimate based on a high hypertension burden, where it gave us a prevalence rate of 8 to 10%. This study was guided by the framework of proceed, where the only part of the first part, the proceed model, was included, where it structured this scoping review, where the predisposing factors included, as mentioned earlier, the hypertension, diabetes, HIV, age, sex, obesity. They were the predisposing factors of CKD. Then the enabling factors included the healthcare access limitations, the delays in referrals of patients, and the lack of CKD registry. The reinforcing factor covered the poor disease management, the cultural reliance on traditional medicines, Then this study showed that the access to kidney dialysis in South Africa, it has been marked as an equity service whereby the majority of patients who benefit from this dialysis are on urban areas. They benefit more than the rural population. Okay. The challenges that we had for CKD in South Africa. One of those challenges is the high prevalence of risk factors, the limited access to renal replacement therapy, the economic and social burden, where it shows that only the provinces that are economically advantaged, they are the ones that benefit from this dialysis and transplantation. The significance of this scoping review provided a comprehensive overview of the existing literature of CKD, and it identified the research gaps on CKD for South Africa, and it informs the policy and practice, where it's suggesting the future research so that at least we can have a lot of studies done on this, more especially on the challenges that we identified on this scoping review. Then the recommendation of this study first is to integrate the chronic disease management, whereby we should, at least when the clinics and the hospitals, when they manage the HIV patients and the diabetes patients, they should not only focus on this, they should also try by all means to screen for chronic kidney disease. At least if those diseases are diagnosed earlier, we can prevent the end stages whereby the patient needs the dialysis and the transplantation, which is highly expensive, and it's not easy for patients to get that service. Okay, in conclusion, chronic kidney disease in South Africa is characterized by high and variable prevalence, the strong links to communicable and non-communicable risk factors. The addressing of this burden requires a multifaceted approach by integrating the CKD into other chronic disease programs and strengthening the national surveillance, ensuring equitable access through health system reforms. This is the reference where we got, some of the reference where we got the literature. Then this marks the end of my presentation.
Okay, thanks for a very insightful discussion on your slide. However, the concept, pardon you, the concept of CKD, it needs more time, ma'am. So in 10 minutes, it might be a bit puzzling to can juggle through the slide. I think time for questions, she already spent some. Huh? How many? Okay, just one question.
Okay, thank you so much for the presentation. You're doing a PhD?
Yes.
Okay. And you're scooping, I think you bite too much that you can chew in this scooping review. Let me be, because of time, when you were presenting the results on the prevalence across provinces, we have 9 provinces in South Africa, and then you have 9 studies also, one for each. So does it mean in your scoping review, you identify only one study per province, or in total you have 9 articles
we have a lack of literature when it comes to CKD in South Africa. So if you check on those articles that we got, they were the ones that meted the eligibility criteria.
In each of the provinces, and then you cited 111 article. So I'm saying that, does it mean in each province you found only one article?
We skipped others. Because the prevalence rates were included in the ones that were presented here. They were somehow similar.
Okay, just have a trial with Prof during but let's give her a round of applause as she takes a seat. Okay, that's mine. Thanks. Okay, the next presenter, it's Raposhe. MJ, not so sure. They didn't underline who's going to present for this. It's you. Okay, you might ascend the stage. Let's go. And a topic is as follows: determination of the medicinal benefits of Keynote africana, antimicrobial, and what? Immunomodulatory what? Activities, yes.
Thank you.
Good day, everyone. I am Rapporteur MJ, and I will be presenting my study on the determination of medicinal benefits of Keynote africana, antibacterial, and immunomodulatory activities. So our bacterium of interest is E. coli, Escherichia coli, which is a gram-negative bacterium, which is normally found in the human gut as part of the normal flora. Some strains of this E. coli are harmless, but then we have pathogenic ones which can cause infections like sepsis, meningitis, UTI, and also diarrhea. So currently this E. coli is being treated with certain antibiotics like penicillin, ampicillin, carbapenems, and the others. So resistance, unfortunately, has developed. And with that being said, this is a global health problem because now it increases, because now it increases mortality rate and infections become very difficult to treat, and the hospital stays also become longer. So when these modern antibiotics fail, we now look back to the medicinal plants, which are considered to have phytochemicals, which are substances that can protect these plants from certain pathogens. So scientists have discovered that we can now use these plants to also see if they can fight some of the infections. So using these plants is very advantageous because now they are easily accessible and they're also culturally accepted, and they are very affordable for those that cannot afford the medical care from the hospitals. So now our plant of interest is Keynote africana, which is also known as a sausage tree, and it has already been traditionally used in medicine for infections, cancer, inflammation, and etc. So beyond its antibacterial effects, this plant extract can also affect the immune system, which is now known as the immunomodulatory activity, meaning it can either suppress or just regulate the immune system. So upon encounter, when the body encounters a foreign substance, we know that it's going to try to eliminate whatever it is. So firstly, we have neutrophils, which are the first immune cells that are recruited to the site of infection or pathogen entry. These neutrophils are going to try and eliminate the pathogen by releasing reactive oxygen species and also nitric oxide, or either by phagocytosis. So now we also have lymphocytes, which form part of the adaptive immunity. These lymphocytes also proliferate, meaning they multiply in order to try and eliminate a certain pathogen of interest. So now investigating this Kigella africana could provide insight into its therapeutic potential. So our objective is also, the studies aim to evaluate the antibacterial activity of Kigella africana against E. coli, assess the proliferation of lymphocytes, and also measure the ROS and nitric oxide production in neutrophils. So this is Kigella, a picture of Kigella africana, and for figure 2 we also have E. coli. And then our methodology, our plant was collected at the University of Limpopo. It was allowed to dry, and it was grinded into powder and extracted using ethanol. And fourth year volunteer student, they volunteered to donate blood in order to get the immune cells that we mentioned, lymphocytes and also neutrophils. So in order to isolate the blood cells into different layers, we used Max Express separator. And then for antibacterial activity, we used the recessorant microtiter assay. And then for lymphocyte proliferation, we used the WIST-8 assay. ROS production, fluorometric assay, and NO production, we used the gradient assay. So for data analysis, this was analyzed using the GraphPad version 10. And then the statistical test used was one-way ANOVA, and the test is considered significant at P is less or equals to 0.05. So we move on to the results. So the first results are the one of antibacterial activity. So in the first bar, that's where we have an untreated E. coli, which is not exposed to anything. And then for the second bar, we have ampicillin, which is one of the antibiotics that is used to treat E. coli. So from 15.6 till 500, that's where we have our E. coli exposed to the plant, which is Kigella africana. So you can see that at 15.6, at low concentration, there's less effect of this Kigella fruit extract. But then as we increase the dose of this plant, we can see that now the inhibition growth of this antibacterium decreases. So meaning that this Kigella africana can be used as an antibacterium for this E. coli. So moving on to the effect of Kigella africana on lymphocyte proliferation. So first bar we have the cells only, and then second bar we have cells plus LPS, which is known as a stimulant. And from 15.6 until 500, we can see that there's an increase in the cell viability, meaning now that this plant affect the cells. Okay, so this plant has a proliferative activity on this lymphocyte. So as we increase the dose of this plant, we can see that more lymphocytes are being produced and multiplied. So for the raw species production by Kigella africana, this one we used cells plus PMA, and then which in this one we had like a dual effect, meaning that this plant here was inhibiting the reactive oxygen species at low concentration, but then at high concentration it is actually stimulating, meaning that it can like act on both ways. If like we're having a case of inflammation, when we have to like lower down the activity of the immune system, we can opt for this Kigella africana. And if we want to stimulate the immune system, we can also use it at a higher dose. So also for nitric oxide production, which we got almost the same result as for using, as for ROS production, in which also at low concentration of the plant, we are having inhibitory reaction, and then at high concentration, that's where we're having more production of this nitric oxide. So as for discussion part, Kigella africana demonstrated a dual activity. Firstly, it is a strong antibacterial activity against E. coli, and it can support traditional medicine use to isolate and identify active compounds. And then for immunomodulation effect, it stimulated lymphocyte proliferation, and then it also showed a dual effect, as we mentioned, due to the dose dependent, meaning that the effect depends on whether we are adding on a small amount of the plant or a higher dose. So for the limitation, the experiments were done in the lab in vitro, so meaning that if this the study was to be done in vivo, we might get different results from this one. And then also the use of crude extract, meaning that this plant does not specifically focus on one phytochemicals. It can either look at the polar, the non-polar, or the intermediate. And then only one strain was tested, which was E. coli, meaning that we cannot conclude that Kigella africana can be used as an we cannot conclude that this E. coli, we cannot conclude that this plant can be used as a treatment for all bacteria, because we only tested on E. coli. And then for conclusion, this finding shows that crude fruit extract of Kigella africana inhibits E. coli activity, which suggests that they can be utilized to treat E. coli infection. And then it can also modulate the immune system depending on the dose. And then the effect suggests that the plant has bioactive compound with potential as antibacterial agent and immunomodulators. This warrants phytochemical investigation to isolate and characterize the responsible for phytoconstituent to know which part of the plant was the one that had this effect on these immune cells, and also E. coli. So this are my reference, some of the reference that I used, and the acknowledgement, Mr. Ndlovu, and the others. So thank you.
Okay, no, thanks for your insightful presentation as well. We are learning a lot from you guys. I will just, with time, which is still fine, if I can at least take 3 questions from the floor.
Okay, thank you for the question. As for the type of E. coli, I just know that we used the multi-resistant strain of E. coli. It was not specified, unfortunately. Okay, so since we are final year student, this was the specific topic that was given to us, that we must focus on E. coli. Yes.
Just one question. Let's protect her now. Just one question and close.
Okay. For the presentation, that's wonderful at undergraduate level. It's quite good. And you indicated some limitations, so I encourage you that after this, then you can take that as your master's.
Oh,
thank you.
Thank you. Thank you.
Okay, no. Okay, on my part, what I can do is to close the session, but I have to observe protocol. My part, it was just to be a chairperson for the session, so meaning it was only to guide the proceedings. And I would like to thank you all for your patience. You exercise maximum patience. You know, sometimes we deviate from the norm. If it's 10 minutes, sometimes other people might go beyond. So, but for the maximum patience you portrayed, I really want to thank you guys. Maybe we can give ourselves another round of applause. Okay, so from my side, I'm not too sure if I can just pass to Prof. Gun to close, or there will be, yes.
Okay, thank you so much for the patient with us for the day. I think tomorrow we start 9, exactly 9, and then we'll be on time. Tomorrow we have to close early for us to prepare for the evening. And then we also, after lunch, we also have 2 in-house workshops, which I think will be beneficial to you. So please sleep early and wake up early. And then by 9, we start. Thank you so much.